IFICS Treasury. So a big thanks to delegates for all these sessions. What I'm going to do as people are joining in is to just remind them about something what is known as IFICS Treasury, and I'll share my screen. So what IFICS 2020 has been is not just a series of 8 sessions of lectures. We've had many other things which have happened in IFICS 2020, and one of the ideas has been what is known as IFICS Treasury. So what is IFICS Treasury? It was a collection of pre-recorded lectures which happened by national faculty on different topics, and this was put together not only by the team IFICS, but we had like Alibaba and 40 Thieves, we had team IFICS and 50 contributors, and these 50 contributors contributed to IFICS Treasury. And this week at IFICS Treasury, we have added few things, and these things which we have added for IFICS Treasury this week are session 7 and 8. Session 7 is injuries around the knee. Session 8 is injuries around the spine. So we would request all the delegates to go through these lectures, which are short, precise lectures, which are prepared on the topics. We also have recordings of all the previous sessions available to all the delegates on IFICS Treasury. So if anyone still has no access to IFICS Treasury, you know the person to catch. Ashok, please raise your hand. So Ashok's phone number and email is with everyone. Those who don't have access to IFICS Treasury, please contact Ashok, and he will be able to help you out with this treasure of knowledge on pediatric fractures. So as people are joining in again, let me go through the content of Treasury session 6, 7, and 8 here. And 1 second. Are you able to see my screen?
No.
Okay.
Yeah, now we can see.
Now we can see. So for the knee session from Dr. Hitesh Shah, Dr. Tushar Agarwal, Dr. Jagdeep Damele, Vivek Srivastav, Chintan Doshi, and Mohan Parwani, they created almost 8 lectures, and these are all available online, and these are the topics of the lectures they have taken for all of us. And I'm very happy to say that delegates have been really watching this treasury in big numbers. We've been watching these numbers, and for this session, there are 2 talks, one on review of literature of cervical spine trauma in children, and second talk is on review of literature on thoracolumbar spine trauma in children, prepared by Vijay Sriram, Arjun Davle, and Sarang. So please go through these talks, and we'll have IFICS quiz again for the last session and today's session. It will be released on Monday, and the answers will be provided to you online because we don't have any IFICS session coming up. And as usual, last 28 days, we had edition of this IFICS daily newspaper where we presented to you one paper published in literature which was most relevant to the fractures which we're discussing. And today is the last edition of IFICS Daily. From tomorrow, this paper would stop. So it stopped publishing from tomorrow till the time IFICS happens again. So it's 6:21, and I would say again, this is IFICS standard time. We are ahead of time in many ways. We were supposed to start at 6:30, but we will start a proceeding early so that we get more chance for discussion. So I would request Premal to carry on with further proceedings for this session. Hi, Premal.
It has been a wonderful journey of this 4 weekends coming to end, and as we already mentioned, I think IFICS is not a conference, it has become a course that we have pondered upon so many topics of pediatric trauma, and today we have come to end where we are going to have a fantastic session on pediatric spine by invited guests and very senior Indian authors as teachers as well. So I would first like to introduce our foreign guest. I'll request Sheetal to introduce his colleagues first, and then I'll introduce our Indian friends. Sheetal?
Yeah. Can you hear me?
Yeah, very well.
Okay, good morning, everyone. Welcome to the last session of IFICS 2020. We are going to have a spine session. I'd like to introduce our faculty from the US, Dr. Patrick Cahill. He is Robert Campbell Endowed Chair, Director of the Wiss Campbell Center for Thoracic Insufficiency Syndrome. And along with Patrick, we have Dr. Viral Jain, who is Associate Professor of Orthopedic Surgery from Cincinnati Children's Hospital. And both of them are going to give spine talks, followed by case discussions. Next slide. Okay.
So thank you, Sheetal. We have a very distinguished guest from India, and I don't think anybody in India doesn't know Dr. Rajsekharan, but since we have a lot of foreign guests, I have a pleasure to introduce Dr. Rajsekharan. He is a chairman and of the Department of Orthopaedics and Trauma and Spine Surgery at Ganga Hospital. Currently, he is a chair, AO Spine International Board, President-elect Asia Pacific Spine Society, and chairman of Constitutional Review Committee of APOA. And he has had multiple very prestigious positions he has held in past. We welcome, sir. We are going to have a fantastic time with you in a subject which we are little ignorant of. Another colleague with Dr. Rajsekharan is our friend Vijay Sriram. He's a consultant pediatric orthopedic surgeon and spine surgeon at Sri Kamakochi Trust at Chennai. He's an avid photographer, and he has clicked beautiful pictures of multiple POSI meetings and all of us during all those meetings. Arjun Dhavle is a consultant spine surgeon at Sir H.N. Reliance Hospital, Mumbai. He is an assistant honorary consultant at Wadia Children's Hospital, Mumbai. He is a very well fellowship trained at Alfred DuPont Hospital and many other places, and with Dr. Ashok Shawri as well. Dr. Sarang Rokde is another pediatric orthopedic surgeon and budding pediatric spine surgeon from Nagpur. He is also a fellowship pediatric orthopedic trained surgeon and has worked at BJ Wadia Hospital for Children. It is great pleasure for me to introduce and invite Dr. Narsimha Ramni, who has been past president of POSI, vice president of Pediatric Orthopedic Foundation, New Delhi. He is a senior consultant pediatric orthopedic surgeon at Indraprastha Apollo Hospital, New Delhi, and he has a special interest in hip and spine. And all of us at POSI know him. He's the voice of Kishore Kumar and sings beautiful songs in all the POSI meetings and after meetings which happens in the rooms. It is great pleasure for me to invite current POSI president, Dr. Dhiren Ganjwala. He is a close senior friend of mine. We hail from the same town. He has a special interest in neuromuscular condition, and he's a leader of Save the Hip project, and he is also a motivational speaker, and he's the one who has taught how to make beautiful presentations to almost all the POSI members. I am a member of Team IFICS. I'm a pediatric orthopedic surgeon. I run a small YouTube channel where I have a lot of common pediatric orthopedic conditions. I enjoy reading, traveling, and singing besides doing IFICS once or twice in a year. With this, I think I'll hand over to Dr. Patrick. I'll call Dr. Patrick to start sharing his screen so that we can start proceedings maybe 2 minutes before the time.
Thank you very much. That's a tremendous introduction. And I just want to thank the course organizers and the chairperson for inviting me. It's a huge honor to be part of IFICS this year. And I'm excited to be talking about cervical spine injuries in particular, which is an important area that that is underappreciated when we talk about spine trauma and trauma in general in our pediatric patients. These are my disclosures. I'll spend a little bit of time at the beginning talking about some of the anatomy and why that's important in our pediatric patients. I'll talk about the epidemiology, most of which is published. It has to do with US patients, but I'm sure there's similar things throughout the world. And then I'll really focus on the specific fracture patterns and surgical management. So fortunately, cervical spine injury is relatively uncommon. It's about 1% of all pediatric spinal fractures. And when you combine adult and pediatrics, it really only accounts for about 2% of spinal cord injuries. And that just speaks to the resilience and plasticity that our pediatric patients have in their central nervous system. In the United States, the incidence is about 7.5 per 100,000. The younger the patients are, the less common the injuries are. And that fits with patterns of spinal cord injuries in general, where there's a bimodal distribution, with the very elderly having a little bit higher incidence, and then also young males being more risk-taking and doing activities that put them at risk for cervical spine injuries. So the most common age range is children between 11 and 15. Again, more males than females because of the risk-taking mentality that goes along with that age group. And unlike the adults, the spinal cord injuries tend to be a little bit higher in the cervical spine. There could be higher than what we're reporting, because a lot of those patients go undetected. And certainly if autopsies are done on patients that die due to vehicular trauma and other forms of trauma, it's probably a little bit higher incidence of cervical spine injury. So the etiology can be in the very young patients due to obstetrical causes. It can be due to child abuse, especially in younger patients where they don't have head control. And then as we get older, it becomes more of the typical forms of trauma, such as falls and vehicular problems. And then in the teenage patients, it also involves participation in sports. So I will say that in the US, our pediatric societies, the American Academy of Pediatrics, has position statements against only 2 activities for children to participate in. One of them are 4-wheel motorized vehicles, and the other one are trampolines, both of which seem to be associated with a lot of spinal cord injuries in our patients. So, and some of the important anatomic considerations are that pediatric patients have a relatively large head size compared to the rest of their body, which makes it harder for them to control their head, but also it makes it a little bit different in terms of how forces are imparted to the cervical spine. In general, spine fractures occur at junctions between areas that are relatively rigid and relatively mobile, such as the thoracolumbar junction, and also the cervical thoracic junction. And then when you look at the weight of the head, it's also the upper cervical spine is a little bit more frequently injured in pediatric patients. Also, our patients have more hypomobility and ligamentous laxity. When we talk about evaluating patients that have trauma and maybe have a cervical spine injury, the rules apply here as they do to anybody else in the trauma bay, in terms of really relying on physical exam. Doing a quick but comprehensive neuro exam is something that can be done in about 1 minute in a patient's emergency department, or in the trauma bay. I'm not going to review for our audience here kind of where the dermatomes and myotomes are, and what reflexes correspond to which area. If you want, I'll make this talk available, but my daughter here was kind enough to show a thorough neuro exam that can be done in about 1 minute. If we're talking about spinal cord injury, it's really important to delineate whether there's any function whatsoever, which portends to a much more positive prognosis than patients that have a complete injury. And then keys with initial management: don't let the head and back move, immobilize, don't use traction until you get imaging to determine exactly what the pattern of the injury is. Also, an important consideration is that due to the larger size of the pediatric head, they should not be immobilized on a flat table or a flat trauma board, but has to have some sort of cutout for the head, or an elevation of the chest and thorax to allow for the room of that head. Spinal cord injury, we also have to consider the spinal shock, where the patients may not have neurologic function, but that's just a temporary physiologic impairment of the function of the spinal cord, and may not be indicative of permanent spinal cord injury. We use the Frankel scale, which is similar to the Asia classification system, where an A grade is a complete spinal cord injury, proceeding to, in less and less severity, to an E, which is a partial injury. And then there's all the incomplete spinal cord injury patterns, such as Brown-Séquard, where there's ipsilateral motor paralysis and contralateral pain and temperature loss. Evaluating for spinal shock, the way to do that is the bulbar cavernosus reflex, where there's traction on the glans penis, and there should be a contraction of the anal sphincter, or also it can be done in female patients as well, with tension on the Foley catheter. It usually lasts less than 24 hours. That's the key time when we have the ability to change the course for patients that have an injured spinal cord. For patients that do have physiologic shock due to a neurologic injury, the treatments, you would see bradycardia and hypotension. The treatments are volume and pressors to maintain flow to the spinal cord. It's controversial, but patients that do have a deficit, we generally use steroids in the emergency department based on the findings of the third NASIS study for spinal cord injury. So one of the questions is, what x-ray should we always get? The lateral cervical spine x-ray on almost every trauma patient. In pediatrics, the rules are a little bit different. We look for soft tissue swelling. We also just look for relative alignment of the bony alignment of the bony anatomy. There's a lot of different measurements you can look at, particularly in the occipital cervical junction. I won't spend a lot of time detailing those. Some of the things that are important to remember is that there's incomplete ossification, particularly people get fooled by the synchondrosis at the base of the dens. And then I'll talk a little bit about Sciorwa. So this is spinal cord injury without radiographic abnormality. So this was a very hot topic maybe about 20 years ago, before widespread axial imaging with MRI was common in emergency departments, and patients, pediatric patients, were coming in with paralysis and neurologic deficits without evidence of fracture on X-ray, and this is largely related to the ligamentous laxity and excessive motion that pediatric patients have, and their spine anatomy allows for range of motion that is beyond what is physiologically tolerated by the spinal cord itself. Now that we have MRI imaging, a lot of these patients, it's evident that there's spinal cord edema and injury within the spinal cord. So it's probably not any radiographic anomaly, but really more of a without X-ray anomaly should be how it's described. So there's advantages and disadvantages of different imaging. When there's a neurologic deficit, MRI is important. If there's a fracture identified, CT to further elucidate the pattern of that fracture is also important. So there's a role for both, and oftentimes when there's an injury, both are done. So there's a lot of things that can be seen on MRI that look at the soft tissue, such as swelling and disruption of ligamentous things. The adult literature on spine and cervical spine injury puts a lot of emphasis on swelling of the posterior ligamentous complex that's important for stability of the cervical spine and flexion and extension. In pediatric patients, just like with say an ACL injury, where the injury often occurs through bony attachments, I'm less concerned about edema in the posterior elements, and I'm not going to use that as clearly as an indication for surgical stabilization, because a lot of times it's an avulsion of an apophysis from the spinous process or something like that, which can still have bony healing to restabilize the spine. I'll skip this and just say that we have a pretty comprehensive document on the website of the Children's Hospital of Philadelphia about a rational clearance pathway for cervical spine injuries. One of the concerns for us was that we were getting called with every trauma patient to say, oh, go clear the cervical spine, where it could really be done by emergency department physicians and trauma physicians without having to involve us with every single case. But also we didn't want to miss any subtle things. So I will refer you to that, and then I'll get quickly into specific injuries and how to manage these. And I'll start at the top of the spine. So this is an occipital condyle fracture that came to see me came into our ER about a year ago. You can see here this fracture. The key here was to look at the overall alignment and stability. I felt that this would heal fine in this alignment, but interestingly, advanced imaging on CT also showed that it went through the vertebral artery foramen at C2. So when there's a damage of that area, we also had to keep the patient anticoagulated to avoid any blood clots that could form from that. And some of the important ligamentous anatomy at the junction of the skull to the spine are these structures right here. The transverse ligament is important for stability at C1 and C2. So the primary stabilizers that hold the relatively heavy head in the pediatric patients onto the cervical spine are the alar ligaments and the tectoral membrane. Again, so the tectoral membrane is extending here from the base of the skull. And then the alar ligaments are the dental ligaments going from the dens out here to the base of the skull, from C2 to the skull base. And this is less stable in pure traction and translation. So a lot of the evaluation may show that it's aligned on the lateral other than distraction and that level. Atlanto-occipital dislocation is rare, and it's a common finding on autopsy studies post-trauma, where a lot of patients with very high energy trauma that perish at the scene of the injury also have this injury. So again, we don't know the exact incidence, but as we're getting better with managing trauma, we're probably going to see more patients surviving with this injury that require treatment. So if this does occur, it requires a fusion from the skull, usually between C1 and C2 as well, to get enough anchors distal to that dislocation. And some of the findings can be cranial nerve problems, spinal cord injury, and respiratory distress as there's traction on the innervation to the diaphragm. So atlanto-occipital subluxation, oftentimes no specific bony fracture, and thus it needs to be surgically stabilized if it is indeed an injury that's identified. So we'll look also at the C1 anatomy, and it's easy to get fooled by some of these synchondroses, particularly in the anterior arch of C1, to think that there's some sort of fracture, such as a Jefferson fracture, when in fact it's just the normal anatomy. So again, the Jefferson fracture in children, in adults, we learn that it has to be a bilateral injury, that the ring can't just break on one side, but due to the relatively plastic nature of pediatric bones, there can be a unilateral Jefferson fracture. And this is where the findings with the synchondrosis can be a little bit confusing. Clearly, this patient is closed on one side and beyond the age of where that synchondrosis closes. So this is a fracture, and needs to be managed appropriately, generally with immobilization, because it's not displaced. And the keys to look for are asymmetry of the lateral masses on the odontoid view to diagnose the Jefferson fracture. Another important concern is the synchondrosis of the dens. This is the weak link, and this is where, if there's a dental fracture, this is where it's going to occur. And this synchondrosis closes between ages 6 and 7. Again, the treatment is, if this is aligned, then the treatment is immobilization. If it's not aligned, then there has to be some sort of surgical stabilization. In general, for pediatric patients, it's very difficult to do an odontoid screw, so the treatment is a fusion at C1 and C2. And the mechanism is a flexion distraction type of injury. And the odontoid almost always translates anterior to the body of C2. So again, this is a picture of performing a fracture, a fusion at C1 and C2. So immobilization is the standard and the kind of the most common treatment I have for cervical spine injuries. As I said, I'm not as concerned about instability. Children tend to restabilize once bony fractures heal. So that's not as strong of an indication for surgical management. And I think most patients with cervical spine injuries can be mobilized with a collar and or a halo. I prefer a halo in most cases. This is another specific instance. We talked about that synchondrosis being the weak link in the C2. This is a patient who came to see us at age, I believe, 10 with a 1-year history of headaches, but had some instability at the upper cervical spine and that reduced on extension. Further evaluation reveals the os odontoideum. This is that well-corticated tip of the odontoid, which moves with C1 and flexion and extension, but does not move with the rest of C2. So there's no real chance for this to heal, and this is a common finding, the os odontoideum. So the treatment here is fusion. We were part of a multi-center study that was published in JVJS within the last year or so. A third of these patients either presented with or eventually developed neurologic findings And so strong indication to consider surgical stabilization if there's any concern of excessive motion or decreased space available for cord on flexion views. So again, here's the C1-2 relationship, the odontoid's in the middle there, and stabilized by the transverse ligament. And this can be disrupted with patients with ligamentous laxity, particularly Down syndrome, it's common, but also for traumatic causes as well. And in those cases, the treatment is fusion. Atlantoaxial rotatory subluxation is a common office visit reason for a patient who's had a previous upper respiratory infection. The treatment is to diagnose this early, initiates anti-inflammatories, traction. If the infection in the pharyngeal region requires antibiotics, appropriately treat that. And usually it reduces. For the late presentation of these, it often requires hospitalization of traction until it reduces and then a fusion to keep it stabilized. Hangman's fracture also happens in pediatric patients, which is a fracture essentially at the pedicle of C2 and leading to spondylolisthesis. Again, the treatment is fusion. It's fraught with danger to try to restabilize this surgically. So really try to get the alignment with traction before you get in there. And lower C-spine anatomy, the vertebral foramen precludes pedicle screws in most levels between C3 and C6. Although at C7, you can sometimes get a pedicle screw because standard anatomy is such that the vertebral artery is not in the vertebral foramen at C7. And so we'll speak about subaxial injuries. The patterns are similar to adults, with burst fractures being common, spondylolisthesis, spondyloptosis being common. The canal has much less room to tolerate retrolisthesis of bony fragments. So if there is any canal impingement with a burst fracture in the subaxial spine, generally the treatment is going to be fusion to decompress and stabilize that area rather than letting it heal as we might in the thoracolumbar spine. So as patients get older, the patterns become more similar to adults, and that's where these injuries occur, and the treatments are similar to adults. If there's no retropulsion and no bony problems, a lot of these can be treated non-operatively. Otherwise, my preferred treatment for a burst fracture is an ACDF like this. Facet dislocation, the treatment is traction to reduce the facets, followed by stabilization. And my preferred stabilization, again, is an ACDF rather than posterior elements because of the increased bony surface for fusion and stability that occurs with that. Just be careful with traction that you don't further retropulse a disc fragment that may not be visible on X-ray, and be ready to emergently perform an ACDF should somebody have worsening of neurologic symptoms with the initiation of traction. And younger patients get more pins at less insertion torque. And so generally the rule of thumb is a 6-year-old patient gets 6 pins at 6 inch-pounds insertion torque, whereas an adult would get 4 pins at 8 pounds. And then you can adjust that as you get younger patients and things like that. Also, you have to keep in mind that you need different size circumference of pins. And probably if you're going to be considering posterior instrumentation, a 3/4 ring would be appropriate so you can get to the upper cervical spine. There are some specific injuries that occur with breech presentation. Forward-facing car seats are a problem in this country, and I'm sure in yours, where a sudden deceleration leads to upper cervical spine injury and distraction. And then unfortunately and sadly, shaken babies, due to the relative weight of the head, have a high incidence of cervical spine injuries. Also to note, pathologic fractures should be in our list of concerns when we see collapsed vertebrae with relatively small amounts of energy and trauma. And a recent study from Mayo Clinic showed that only about half of these are sort of benign kind of tumors, such as LCH or things of that nature. So it's important to get a diagnosis and not just treat these expectantly. So I'll talk briefly about my instrumentation techniques. Skull base, the key things to remember here are that the thickest bone is in the midline, and it's a mature bicortical bone, and you want to template the thickness of this. This is the keel here, so that you can ideally get a bicortical fixation, but no more than bicortical fixation with your screws. And there's all kinds of instrumentation and plating systems that can allow you to get these screws into place. One of the techniques that was developed at CHOP by Dr. Dennis Drummond was this using the thick periosteum of the pediatric patient and folding it down as a flap to augment the fusion healing in pediatric patients. Leads to a really nice robust bone when you're doing a fusion to the skull base. In one of my patients who had a previous decompression of the skull base and also had a bony condition where the bone was very thin at the skull base, there was not adequate room for occipital screws, so we used occipital condylar screws, but then we had to map out the arteries in that level, and just keep that in mind. When we're talking about instrumenting C1, the keys here are to plan the length of the lateral masses of C1. So we measured 14 millimeters, but these screws then extend another 10 millimeters until they're beyond the posterior arch of C1. So it's a 14 millimeter threaded portion plus 10 millimeters of unthreaded portion when it runs next to the C2 nerve root. Some of the tips I have for positioning in the cervical spine: position the head flex forward in the military tuck position for screw insertion, so that it opens up the gap between C1 and C2 to allow access to C1. And then once the anchors are in place, then you can put the patient in the position that you want to lock them into, and then place the rods. And then some of the other keys with C1 are that the undersurface of the arch of C1 needs to be burred so that the screw can get in there. And then the other key with this is the C1 nerve root is right in the area where that screw is, and there's no downside to really cutting that C1 nerve root, as long as you educate the family that they may have some numbness on the back of their head long term, but there's not any negative functional consequence to that. Here's the occipital condyle screw I was discussing before. Again, mapping out the arteries before I place that are important, because the tortuous anatomy of the vertebral arteries are such that they basically pass inferior and medial to where these screws go in the occipital condyle. For C2 fixation, there's a couple different options. My preference is translaminar screws. This is relatively safe. The spinal canal at C2 is very capacious, so you can actually even do things like supralaminar hooks or infralaminar hooks at C2. Generally, the lamina is pretty thick and has a 3 millimeter or so cancellous canal. The keys here are to make sure one of these starts relatively low on the base of the spinous process on one side and the other relatively high. So as they cross each other, they have room. And if some of these threads do penetrate into the canal, it's not the end of the world because of the wide canal that exists at C2. And then one of the other keys is that these are the screw heads take up some space on the midline. So placing your bone graft before the rods go in is important to get a good fusion. And some of the people that don't like that as their preferred treatment argue that it's potentially has a higher rate of pseudoarthrosis. But in my mind, it's a lot safer than this, which is a C2 pedicle screw. The treatment here is to really visualize the medial border of C2, and then also image as you're going in, and also template the angle of medialization that each C2 pedicle screw has to take. And then lastly, also looking at your advanced imaging to make sure that there's not a medial positioning of the vertebral artery. So this is a congenital anomaly case I had, where we then identified the appropriate angle and identified where the vertebral artery was. The starting point is relatively lateral, so make sure as you're dissecting laterally, you go slowly and don't get into the vertebral artery, which could be a fatal mistake. And these are just some of the images of what a C2 pedicle screw looks like. For subaxial fixation, and this is a C2, these are C2 pedicle screws. Subaxial fixation, the treatment are lateral mass screws. In pediatric patients, these are very small screws. Essentially, you can place a freer or a elevator into the facet joint to figure out the superior inferior angle, and then start just medial to the center of the lateral mass and angle outwards, as you can see here in this bottom right image, to place your screw. And in the pediatric patients, oftentimes these are only 8 millimeters long. So it's very weak fixation and probably needs to be supplemented with external mobilization like a halo. And then dislocated facets, we talked about ACDF. It's a safe, reliable procedure that has good healing and is relatively low morbidity. Other bailout techniques include wiring techniques, and as I said, laminar hooks. I won't talk about Magrill screws and things like that because of the technical challenges, even in adults and with pediatric patients where the bony sizes are even smaller. It's something I don't recommend. So the wiring techniques can be sublaminar between C1 and C2, or it can be sublaminar at C1 with a subspinous process at C2. These seem to have about an 80% fusion rate, whereas the instrumentation techniques that are more rigid with screws tend to have about a 95% fusion rate. So thank you very much. I know this was a whirlwind of pediatric trauma, but it's an area where till now we've just been borrowing rules from adult trauma, and I think there are some specific injury patterns and anatomic concerns with our pediatric patients that warrant specific discussion for this population. Thank you very much.
Thank you, Dr. Patrick, for an excellent overview of cervical spine injury. We didn't know so many injuries exist. I'll request Viral to share his screen and start his presentation. Arjun, do we have a question for Dr. Patrick till we share the screen? Viral, please start sharing your screen.
That was a great talk. Thank you, sir. I'd like to ask you, what is your sort of option for fixation of the subaxial spine in dysplasia children? Because it's difficult to get even lateral mass screws. So
yes. Yeah, that's a great question. So it's really patient dependent. Unfortunately, a lot of times my answer is that we have to get stable fixation above and below this and end up getting a very long construct. So you can usually get cervical 7 pedicle screws and T1 pedicle screws. I usually like about 3 levels of pedicle screws below a construct. And then you can get stable screws, as I said, at C2. So it'll often be a very long construct just to deal with a relatively focal area because I think the fixation in the subaxial spine is inadequate. So then it becomes for things like, as you mentioned, some of the bony dysplasias, it's a tough decision. How much growth are we going to sacrifice by doing a fusion at such a young age? And sometimes we don't have any other option but to fuse most of the cervical spine, and that sacrifices, as I said, growth, but also range of motion. What are your thoughts? What do you like to do?
I do agree with you. I mean, it's one of those tough areas, So wonder what Dr. Rajshekharan thinks about it.
Can we have it at the time of discussion? Can we proceed with the presentation with Viral?
There's one question, Premal.
Yes.
There is a question from Amit Yadav. If the cervical spine injury with subaxial listhesis happens with neurology, should you reduce it in emergency with tongs?
Absolutely, yes. That's a situation where you have to move quickly. You have a limited window to make a positive impact on that patient's long-term prognosis. Ideally, you have the backup of being able to get an MRI scan if the deterioration of the neurologic exam gets worse with that, because as I showed that picture, you can further herniate a disc. But I wouldn't delay, and I would also be prepared to surgically move forward if the traction works and you can reduce the dislocation, but there's still not a return of function. You have to get some imaging to see if there's disc fragments or bony fragments in the spinal canal, and then do an approach and a decompression based on where those fragments are. If there's posterior bony elements, then you're probably going to want to go from the back, do a laminectomy and a posterior stabilization. If it's a disc or some piece of the vertebral body, you'll go from the front and do a corpectomy or a discectomy and do an instrumented stabilization from the front.
Okay, thank you, sir.
Thank you, Dr. Viral, can we have your video on and start your presentation, please?
Yes. I'd like to thank the IFICS committee for giving me this opportunity to present. We're going to be focusing primarily on the established evidence that's out in the literature for thoracolumbar spine fractures in kids. I'm going to try and avoid my personal experiences in the presentation as much as possible. As we know, this is a vast topic and we have to cover a lot of things. I apologize in advance if I run over. And then we're going to try and focus on kid-specific things as we will see. So thoracic and lumbar spine injuries are less common than cervical spine injuries. However, that's not always true, and it's also age dependent. In the patients who are older, usually in the second decade of their life, their injuries are more like an adult, and they are more common in the thoracolumbar junction. In those patients, motor vehicle collision or recreational activities, injuries during those type of things are more common. Whereas in the younger patient, we want to worry about the non-accidental trauma. Neurological injuries are usually high energy and are associated with other visceral or orthopedic injuries, and these are mostly incomplete lesions. And the primary reason about the fractures and the neurological effects are related to the flexibility of the pediatric spine, as Dr. Kale previously mentioned. The growth of the thoracolumbar spine happens from an epiphyseal growth plate, which is essentially adjacent to the ring to the disc, and then is covered by the ring apophysis. The ring apophysis appears radiologically between 8 and 12 years of age, and it fuses with the rest of the body and sort of disappears quite late, up to 25 years of age. You can see that. Biomechanically, three-column spine concept introduced by Francis Denis in 1983 is still valid and is widely used. This anatomical description essentially provides most of our basis of classification as well as the treatment. The anterior column is the anterior half of the annulus fibrosus and the vertebral body and anterior longitudinal ligament. The middle column is the posterior half of those things. And the posterior column consists of posterior arch and the posterior ligamentous complex. Mechanism of injury depends on the age of the patients. In the young children concerned for non-accidental trauma, motor vehicle accidents are the most common type of injuries that would cause fractures in thoracolumbar spine. The classic example is the lap belt, and you may have seen this picture in a previous presentations as well. Fall from a height is the second most common reason, which causes axial loading of the spine. It can cause compression fracture most commonly in kids, but it can also cause burst fracture depending on the degree of flexion of the trunk at the time of the impact. If the trunk is extended, most of the load of the vertebral body becomes more symmetric and it's on the middle column, and it causes a burst fracture. Burst fracture can result in the displacement of the posterior vertebral body into the spinal canal. So there is vertical load, end plate bulges towards the vertebral body, considering that the end plates are sometimes stronger than the soft bone. So that causes deformation of the end plate, eventually results in decreased energy absorption ability. And when the elastic limit of the vertebral body is exceeded, that's when the fracture happens. It can cause disruption of the distribution of forces over multiple levels and can result in multiple compression fractures. When there is true distraction or shear forces, that's when you usually cause end plate fractures, and in the various severe cases can result in fracture dislocation. These are fairly common injuries where you have to look for other causes of other sources of injury. As you can see, there are definite patterns that has been established in adult patients. It's sometimes true in older kids as well, where you can see fractures in the thoracolumbar spine can be associated with the fractures in the lower cervical spine as well. Associated injuries, we'll talk about lap belts, classical sign or syndrome, where you can see ecchymosis on the anterior abdominal wall. These are associated with the intra-abdominal injuries in about 2/3 of the patients and can also rarely cause tearing of the abdominal portion of the aorta. Associated head injuries, cervical spine injuries, and other extremity fractures. Especially if they fall from height, there are likelihood of paired fractures in the calcaneum. These are usually high energy injuries, and so you have to look for ABCs of resuscitation. Patients will have symptoms of pain, numbness, and tingling if the neurological structures are involved. Examination should be performed by log rolling the patient. Look for the areas of the tenderness. One thing is important, as Dr. Cahill mentioned, physical examination is extremely important, has a sensitivity of 87% in identifying these fractures. Neurological examination, we all should know and know how to do it quickly. Radiographic evaluation is important. Your primary method of evaluation is a lateral X-ray. However, it has been shown that CT scan is clearly superior to plain X-ray, and injury is commonly underestimated with X-ray. So up to 20% of the burst fractures are misdiagnosed as just simple compression fractures. The CT scan is not obtained. As you can see, it is very sensitive and has been shown to be cost effective by Gorgon et al. However, there is increased radiation in younger children. You always have to consider that fact. You can see in this example, it looks a fairly innocuous compression fracture here. But when you got the CT scan, you can see there is a definite enterolisthesis. So what is the role of MRI? You always want to get MRI when there is neurological deficiency, even if it is transient or progressive. And then think about scivora. MRI is a prognostic tool as well in the patient with scivora. What is scivora is this, as Dr. Cahill mentioned, it's less relevant in current day and age as a result of a standard of getting MRI in a patient who is neurologically deficient. But it does, in a patient with thoracolumbar fractures, it identifies disruption of the posterior soft tissue complex, and it changes the classification as well as the treatment subsequently. A posterior ligamentous complex injury along with the middle and anterior column injury becomes a 3-column injury. Traditional classification for these fractures is Denny's. Is divided these injuries into minor and major injuries. Major injuries are compression, burst, seatbelt, or flexion distraction, and fracture dislocation. However, the issue with Denny classification is the description of those fractures are appropriate, but it sometimes does not guide you for the treatment, especially differentiating between the surgical and non-operative treatment. So spine trauma study group came up with a comprehensive classification of thoracolumbar fracture. It's called as TLIX. And as you can see, the component, these are based on the morphology of the fracture. And they are, each of these components have been given points. As you can see, if the mechanism is compression is 1 point, if there is burst, we add 1 more point. If there is rotation or translation, there are 3 points. Distraction, 4 points. These are, this is how you determine whether the severity of the fracture requires more involved treatment or not. One of the most important component of this classification is the disruption of the posterior ligament complex. And as you can see, it has given a higher number of points when there is complete injury. And then you add neurological status. Based on those numbers, the management is determined. If the numbers are 4 or below non-surgical, at 4 you can go either way, surgical or non-surgical, and more than 4 it's definitely surgical. The treatment has been suggested based on the numbers and the type of injuries, as you can see in this table. The key thing to remember is that this classification is not widely validated in pediatric population. However, there is a fairly recent paper in Journal of Pediatric Neurosurgery where neurosurgeons validated this classification in approximately 50 or so patients. But that is the only study that I know that has been used to validate this classification. So compression fractures are the most common thoracolumbar spinal fractures, and they are essentially a loss of anterior height compared to the posterior height by about 3 millimeters. The mechanism is axial load inflection. Wedging varies between the coronal and the sagittal plane. You can see wedging in the coronal plane as well. These are rarely associated with neurological deficit. However, if they are contiguous compression fractures, that can create kyphosis. Burst fractures are the severest form of compression fractures. Essentially, there is middle column involvement and there is retropulsion of content into the canal, which can cause a neurological deficit. The fractures are most common at the thoracolumbar junction. There is a concept of unstable burst. Traditionally, what is unstable by Denny classification is a cortical collapse greater than 50%, focal kyphosis of more than 30 degrees, progressive neurological deficit, and retropulsion with canal compromise of more than 50%. However, this is not always considered to be an indication of surgery based on the current literature. So when there is definite three-column disruption, that's when it's a true unstable burst fracture. As you can see, translation of the vertebral body for more than 3.5 millimeters usually suggests disruption of the posterior column. Facet subluxation along with the posterior, again, is a hint towards the posterior ligamentous complex disruption. And as we saw previously, MRI is the diagnostic test. Flexion distraction injuries are Chance or Smith fractures. These are the classic lap belt injuries. It's a three-column injury. We can see on the plain X-ray there is increased interspinous distance. MRI will definitely provide information about the ligamentous complex. Up to 2/3 of these Chance fractures have intra-abdominal injuries, sometimes even the vascular injuries. So when we are talking about flexion distraction injuries, let's talk about the child restraints or seat belts. Arcaders showed permanent neurological deficit in patients who were in only 10% of those patients who were properly restrained as compared to 42% in unrestrained patients. Chance fractures in children usually occurs with 2-point restraint, which is a classical lap belt. When you misuse shoulder strap and use it only for the lower part of the body and you don't actually apply shoulder strain, it essentially becomes a 2-point or 3-point restraint instead of 5-point. That can cause fractures. In a Canadian Trauma Society looked at the Seatbelt Syndrome, and only 18% of those patients who had injuries were actually appropriately restrained. So you can see when you are, it is extremely important to have children restrained properly in the seat, in their car seats. Technically, it is a 3-column injury that involves bone or ligament. So in this picture, as you can see, the injury starts from the posterior aspect and it exits anteriorly through the vertebral body, all throughout it's the bone. So it's a bony Chance fracture. Whereas this one on the upper right-hand corner, you see it's purely ligamentous. Usually there is a mixture of both ligamentous and bony injuries in this fracture pattern. Fracture dislocation is a complete severe failure of the spine with a component of shearing and rotational displacement. Is 3-column injury and is usually associated with dense neurological deficit. So principles of surgical treatment, goal is stabilization, neurological decompression, and early mobilization of the patient. Posterior implementation is the advantages. It provides 3-column fixation. Most importantly, it's a familiar approach. It can avoid morbid anterior surgery and is the most familiar approach nowadays with young surgeons. It's usually in generalizing pedicle screw fixation 2 levels above and below the fractured vertebra. Instrument fracture vertebra if the bone stock is adequate. Thank you, Dr. Kale, for these images. As you can see, when the posterior column is intact, you essentially apply flexion momentum posteriorly, and that will result in restoration of anterior column. When the posterior column is compromised, you apply posterior distraction and restore the height of the vertebral body. Indirect decompression, as we saw in this slide, is appropriate for early intervention when the patient reaches to you within 3 days or so. Average reduction of canal compromise is about 40 to 50%. It's indicated in the unstable burst fracture. Direct decompression laminectomy is usually for the patient who presents late, and transpedicular decompression can be performed. Nowadays, we perform using the pedicle subtraction osteotomy approach. Anterior instrumentation, of course, it restores anterior column. These are more specific for burst fractures. These are essentially necessary when there is a canal compromise and the patient presents late. Again, I thank Dr. Cahill for these images, decompression, restoration of height, and then bone grafting, and then instrumentation. So treatment, compression fractures is an isolated fracture, usually treated with off-the-shelf hyperextension brace. And goal is to limit flexion and pain relief. When the degree of kyphosis is less than 10 degrees, bracing makes no difference in the final outcome. However, you do have to consider symptomatic treatment as well. Most fractures heal in 4 to 6 weeks. Radiographs at 2 or 3 weeks should be obtained to make sure that the sagittal alignment is maintained. There is remodeling potential in these fractures, especially in the younger children. There is some evidence that the end-plate fractures can result in late degeneration. When there is multiple compression fractures, you do have to address the underlying problem of osteopenia, and that is the role where you would contact your endocrinology colleague. You can use a TLSO rather than a simple anti-flexion brace for these fractures, and they may have to vary for long duration. Surgical treatment is extremely rare. It's indicated when the kyphosis is more than 40 degrees of normal, and your posterior instrumentation usually is sufficient. Burst fracture guidelines have been developed based on the adult literature. And the indication of surgery is unstable burst fracture, posterior ligamentous complex, and compromise and progressive neurological deficit. Worsening kyphotic deformity in a non-operative patient is known. Most of these articles are from the adult literature. However, there are a couple of pediatric articles, as mentioned here. They indicate worsening of the kyphosis as the fracture heals. However, there is no real correlation between kyphotic deformity and patient outcome. Stable burst fractures usually treated with extension molded cast in young patient or specifically made extension TLSO. Duration of immobilization is 2 to 4 months. Unstable burst fracture treated commonly with posterior approach. When they present late, you should perform anterior decompression and fixation. Flexion distraction injuries are typically 3-column injuries, can be treated in hyperextension cast when it's purely bony chance fracture and the patient is young, as they are able to tolerate the cast well. The exception in this rule is when the patient has multiple abdominal injuries and we cannot reach and provide appropriate treatment in reasonable amount of time. In that case, you should take the patient to the OR and perform stabilization. In a patient who has purely ligamentous injury, and the surgery is definitely indicated. There's no role of conservative treatment on those patients. Instrumentation is usually, fixation is usually performed in compression, as you can see. And in this particular case, as you can see, it's sort of a bony chance fracture treated just by no fusion and just by instrumentation. You can also perform, as you know here, in this patient who has purely ligamentous chance, you put 2 pedicles, 2-level pedicles through instrumentation and compress. You do not need to fuse. And then you can have overall better results with surgical treatment as compared to non-operative treatment has been shown in a multi-center prospective treatment. Fracture dislocation always requires surgical stabilization. If there is no neurological deficit, incomplete neurological deficit, instrumentation levels to above and below. Complete spinal cord injury, you have to perform a longer instrumentation. Timing of surgery is controversial, but sooner the decompression, especially with a patient who has neurological injuries, sooner the decompression, better is the neurological recovery. There is no evidence to support use of steroid in treatment of spinal cord injury in children in thoracolumbar area. Special consideration, complete spinal cord injury, where it's almost more than 90% of risk of spinal cord, risk of developing secondary deformity in patients who have complete spinal cord injury, especially at the upper thoracic level, and their age is less than 10 years of. When they finish their adolescent growth spurt, the risk of secondary deformity decreases. This is one of my patients that I performed surgery a couple of days ago, had a total spinal cord injury, polytrauma, initially fixed for the spinal stabilization only. With time, he developed kyphosis. However, he underwent rigorous rehab and he was able to control his kyphosis. Then he started developing scoliosis, and we ended up performing an extension of his fusion of pelvis. Fractures of vertebral rim apophysis, they are also known as limbus fractures or posterior rim apophyseal fractures. Most of these are in L4-5 or L5-S1. Mechanism of injury is essentially flexion with axial loading. However, that's controversial. It can happen in extension as well. Clinical symptoms are classic of a lumbar herniated disc. Extremely rare is cauda equina. However, it has been reported. Classification for these these lesions is primarily descriptive. Diagnosis is based on the high suspicion for the injuries and the positive examination. X-rays are not reliable. As you can see in one of my patients, the X-rays are completely normal. MRI also can miss in the 50% of the cases. As you can see, this was reported maybe some disc herniation. However, when it was read by a neuroradiologist, you see they were able to identify the fracture itself. CT scan is the diagnostic modality of choice. Non-operative treatment is usually not successful, especially in presence of root tension signs. Operation is indicated, especially for neurological deficit and intractable pain. Adequate neuronal decompression is the goal. Decompression does require more extensive exposure. Thank you.
Viral, one of the questions that came through while you were giving the talk was the extent of the posterior construct for a burst fracture. Are there special considerations in the pediatric population to try to save levels, or how many levels above and below do you like to stabilize a burst fracture if you're going to do surgical instrumentation?
So in absence of associated other fractures, because sometimes you will see fractures, compression fractures in the vertebrae adjacent. In that, we usually go 2 above and 2 below. This ligamentous posterior instrumentation. I have done this infrequently with.
Viral, sorry, can you please unshare your screen so that we can have the second talk, please?
Oh, okay, yes. So I have done it percutaneously, and I have also done it open without extensive fusion. But I think 2 levels above and below are adequate. In the patient that I did not perform fusion, I performed the instrumentation only, kept it in for minimum 6 months, and then went back in and took this out. However, remember, these are very uncommon, and the patient that I did non-fusion instrumentation was around 11, so quite skeletally immature.
Thank you, Viral.
One question. So one question is, how different is rehab for children with spinal cord injury as compared to adults? And Viral showed a beautiful case where a child had scoliosis, where an adult would not have the same fate. So Viral and Patrick, both of you, for how is the rehab and the natural history different for children as compared to adults?
So natural history, is favorable for kids when they have complete spinal cord injury. They do gain their function, upper or torso function. They do have some psychological problems during the rehab, but overall they cope it very well. Younger the child is, easier it is for them to get used to the new situation. Most of the patients that I have seen in past 10 years, they have had excellent functional outcome with the use of assisting devices, especially the wheelchair. They have been going to school. They have been fairly happy. They have develop their own interest. I know in United States sports is extremely important, but these patients were able to do alternate sports activities. So overall, the rehab is a lot less challenging. However, you do have to deal with spasticity and the contractures that do happen, and as I showed in that case, secondary deformities. These patients do not tolerate the brace very well, so that is one of the considerations you have to give.
Yeah, I think that's a
So
interesting.
Taral, sorry. Yeah, so
Yes.
Taral, in our country, where there is no organized rehabilitation or government-funded rehabilitation, we have found one of the most significant factors which influence the outcome is the educational status and the economic status of the parents. So when the parents are very well educated, they are able to understand both the short and long-term implications and the program, the child does quite well. So the family situation and the background is considerably important when a child gets a spinal cord injury.
Yeah, I think that's very important. In terms of what can lead to mortality and death in a spinal cord injury patient, it's really the urologic management. So making sure that they have access to catheterization and can educate the family. And then when the children are old enough to catheterize themselves, otherwise they'll have urinary tract infections and renal failure and things like that. So that is probably the most important part of it, which is unique.
So let's start with the cases now. Dr. Rachit.
Okay, yeah. So thank you, Tharal, and thank you very much for this opportunity. So after these two excellent talks, I'll just discuss three cases. We are running short of time, but we will discuss this, all the important aspects. What makes this important is, as Patrick very well said, it's it occupies only 1 to 3% of all pediatric fractures. So there is a lot of gray zone in the minds of not just the pediatric orthopedic surgeons, sometimes in the minds of the spinal surgeons also, because the cases are very few and far apart. Even in a busy spine unit, if you take fractures in less than 10 years old, then sometimes in a year you don't cross a double digit. So that's what makes this very unique. So I'll start off with the first case. This is a 13-year-old girl. She complained of pain in the neck for 2 weeks after a visit to the aquatic theme park. She had an aquatic injury while she came down the slide. And since then has been difficulty in turning the neck. There was a cock robin position of the head, and she had normal neurology. Started off with mild deformity, but over the last 1 week, it was becoming worse. So this is a very typical case. As you can see over here in the radiograph, you can see some mild asymmetry of the joint line positions and the distance between the lateral mass and the odontoid. And you can see very clearly in the CT scan the problem. She has got a rotatory subluxation of C1 over C2. So this is a young girl, 13-year-old, no neurological deficit, acute, if you can call it acute, 2 weeks. and she has come walking into your clinic, deformity and pain. So what would be your thought process and how do you do that? So I'll start off with our internal batsmen. So let me ask Vijay and then Vishal on what would they do when somebody walks into that clinic. Vijay? If Vijay is not on, Vishal?
Sorry.
Yeah, hi, sir.
Arjun here, sir.
So this is a very interesting case. I think the first and foremost, before we even proceed into the details of this, I think we all must understand there are certain normal physiological, radiological findings in kids. And unless until we appreciate those findings, we'll never be able to differentiate the abnormal versus normal. And this is very, very conspicuous, particularly in kids. Like you can see some small wedging at C3, C4, so that should not really be paid too much attention. There is also a slight subluxation at 3-4 also noted. Again, that is something that we should actually miss upon. Now coming to the rotatory subluxation, few things that I would actually want to pay more attention to is the type of subluxation this is. As per Hawkins classification, that's one thing I'll want to classify this, because that not only determines the prognosis of this particular kind of subluxation, but also would want to note if there is any dysplasia noted in the C1, C2. Like I can see on the extreme right hand side, the left facet seems to be a little more angulated if this image is the mid coronal image at that level. So noting about the type of classification, which will be better studied on an axial image, and also the dysplasia of the C1, C2 joint. This will help me to understand whether this is something like which is going to be a progressive dislocation or not. Only once we have understood this, we will be able to know whether this is going to spontaneously resolve over a period of time, or this is going to require some kind of intervention to reduce it. And the primary goal is to have a stable and a reduced C1, C2 junction area. Stable, painless, and a reduced C1, C2 junction. And that more often than not in type 1 patients who have presented early in the course of disease, in the problem, they usually tend to resolve the moment their pain goes away. You just give them a soft cervical collar, they tend to resolve. In this particular case, what is different is this is almost 2 weeks old already, like a 13-year-old child, which is not so young. So physiologic auto reduction of this, one will have to be very careful about. And it is very important that you don't miss the bus. The moment you have crossed a certain period of time, it may actually end up being a chronic subluxation, which will have a permanent disability for the child requiring a bigger fusion. That is why at this point, to assess radiologically the type of classification, number one, the dysplasia of the joint, try to get a stable, painless position for the child and wait for a week's time. If it reduces, wonderful. If it doesn't reduce on its own, probably try a traction, reduce it in the wards. And my take on this child will be that this child is going to require a C1, C2 fusion, and it will not be able to maintain in there because recurrent subluxation, this age group is probably going to be higher.
So Vishal, I mean, we are talking of spontaneous resolving. I mean, that's common in very young people, as really very younger children, much younger children, and probably after a tonsillitis. But post-traumatic and of this severity is rare, as you rightfully mentioned. This will need some intervention. Vijay, what would you do for this? I mean, having known, I mean, Vishal beautifully explained all the things that you need to see.
This will probably not reduce, sir. We can try traction, but it won't. I don't think it will reduce.
So,
yeah, it will. For someone like you, a C1-2 fusion should be quite easy for this. You can reduce it into a C1-2 fusion.
C1-2, C2. So you will start. Patrick, do you think there is any role for a manipulation? I mean, C1, C2 is okay, but in a child, if you have to avoid nothing.
Yeah, 13 years old, sir.
Yeah, I really worry about. I worry about manipulation. I would rather give a trial of traction, maybe as I think Vishal said, a week or so in the ward in traction, let the child get used to it and relax and see if it spontaneously reduces with some traction. And and my hope would be if it does, then treat and immobilize for 2 months, 10 weeks with a halo immobilization. And then see if it remains stable once the immobilization is removed. And only then, if it's still unstable, would I probably consider a fusion. If it doesn't reduce with traction, then I would.
What kind of traction, Patrick? What kind of traction?
Halo gravity.
Halo gravity, walking around. Okay, that's good. Okay.
Yeah.
Viral, anything else you need to pitch in?
So, if the patient comes in relatively early, I've done just a halter traction along with some central muscle relaxants such as diazepam or robaxin. But overall, I agree with the treatment that we have suggested here.
Okay. So, I mean, this is what we did, Gardner-Well tongs, and we gave traction, we gave muscle relaxants, and then this didn't work. And then we were left with the choice of, as we discussed, should we manipulate or should we fuse? So we had everything done and ready for a C1, C2 fixation, but we did try a reduction maneuver gently after anesthesia before. And it's very important that you know the steps of doing it. And the most important thing is to give a gentle traction under anesthesia. If possible, keep a neuro monitoring. You just also do a counter rotation after you're given a gentle traction. And one of your anesthetists or your assistant can push in the lateral mass on the sublux side. You should keep a lateral view of the C-arm going on for a constant monitoring. And while we were planning surgery, we were really lucky that we had a pop and then it went off. So that was really good. I think we were lucky because it was a small child and less than 2 weeks. And we had probably some relaxation out of the 1 week of traction that the patient had. And this was quite okay. And after 8 weeks of immobilization with a collar, I can see that she had a perfect result and she was able to escape a surgery. But as Vijay said, if this is not possible, then if it is in neglected C1, C2, for example, this patient we got after 5 months after this injury. You can see a grotesque deformation and an anatomy here by the CT scan shows what distortion has taken place. Then there's no role in waiting for a conservative treatment. And then we probably need to do that. We have described a technique which is also published in Spine. So in case where you have a problem, then after you position your screws, and because these are so much rotated, navigation is really good for placing the screws. And once you position the screws, rather than connecting the rods from C1 to C2, you can connect the rod between the 2 screws of C1 and the 2 screws of C2. And then you use this with rod holders, and then it really helps you to manipulate. Yeah, it just is a very good technique. It helps you to manipulate, and then once you hear the pop and it is completely reduced, then you can change the rods to, you can see that it is reduced, and then you change the rods between C1 and C2. So here you can see that before and after, you have a very good result. So is there any take-home points? So the take-home point is early on in small children, very small children, less than 7 or 8 years, you wait for a spontaneous resolution. Otherwise, you put them on some traction and give some muscle relaxant. Otherwise, you try for a closed manipulation very gently. Otherwise, you should be ready to do a C1, C2. Anything else anyone wants to add on? Pat, Sarang or Arjun?
So I think this is an important entity, and especially the Grisel syndrome, the patients who come in, with a post-viral fever, and they'll sometimes come in similarly, with a post-viral fever, with a torticollis, which is painful. And that if it's picked up early, usually with traction, early traction in the ward, they will resolve, if they're picked up early, sort of similarly. Of course, if they don't, then they need something. But the key is to pick it up early. The other sort of, corollary to this is, in all torticollis patients, I actually think that one should do a low-dose CT at least, even before presuming that it is a congenital torticollis, sometimes, before you do a release also, since this is the predominant pediatric audience, because sometimes you will pick up some aplasia of the C1, or the C1 or C2. And you may pick up a congenital bony torticollis, vis-a-vis a muscular torticollis sometimes. I think that's important to pick up.
May I, Dr. Raj?
Yeah, please.
So I think 2 points here, like what Dr. Arjun may just mentioned, is to re-emphasize the fact that not all patients actually have torticollis to present with, and very often that rotatory subluxation gets missed because we don't consider neck pain as one of the symptoms of rotatory subluxation. And to catch these rotatory subluxations early in the course of disease, that every neck pain patient with trauma should be evaluated with a CT scan to check for these rotatory subluxations. Then we'll be able to find them really early in the course of disease, which will be better reduced and managed without surgery in the early course. And second point that I would like to bring is that there are certain factors. Ishii et al. Actually in his papers has mentioned that there are certain factors which suggest surgery on day one. I mean, they have straight away ruled out the role of traction or any kind of rotatory maneuvers because they feel that surgery is surely going to be required, and those are the cases with type 2 dysplasia of the C2 lateral mass. And also, while rotatory subluxation happens, if there are chronic changes in the C1 C2 joint, again those are the cases where recurrent dislocation will easily happen even if you have reduced them well. So those are the cases straightforward. Even on day one, you should plan for a surgery rather than reducing them in the wards.
Hey, Dr. Rajsekar.
Good points. And the other thing that we need to be careful is that there is no ligamentous injury, and CT also helps us to know that there is no subluxation. So a suspicion of a subluxation is a contraindication for manipulation. And as you said, there is a dysplasia or some hibernation of bone in a chronic case, then you know that you need to operate. So I would like to ask Patrick
Dr. Rajsekar, I had one question. What is the potential complication of a manipulation maneuver?
Well, if you do it very gently, and if you're not very determined to show your strength on the child, I don't think it's not a problem, because you are going to just try, and you should know very cleverly where you have to stop. I mean, you just try, and if it's only that you go the full length of like a car steering wheel, I mean, that's not particularly on. Otherwise, I am not sure. I don't think there's a big issue out of it. You should know when to stop. If you know that, then I don't think there's a major problem. It will be a problem if you have missed a case with ligamentous injury, or if you have missed occipital cervical dissociation or something like that. That's an absolute. Then the problem is in the wrong diagnosis, but not in the gentle manipulation of rotatory subluxation. Patrick, what do you think about the statement from Vishal that you should do a CT? Your threshold for doing a CT in pediatric children must be very low, because there is so much talk about the negative effects of CT and 16 times increased malignancy in these patients at the age of 50 years.
Yeah, thank you for bringing that up. I think that's a very controversial area. A lot of the efforts in cervical spine trauma have been focused towards which patients can we avoid getting a CT on. So I think the statement was made, anybody that has neck pain should get a CT. This is where I think physical exam is so important. So, do a neurologic exam. If the child doesn't have any neurologic deficits, then you can palpate the cervical spine. If there's no point tenderness, then you can, do a range of motion evaluation. And if the patient has a limited range of motion, that might be a sign that they have this injury. But if the patient has full range of motion without pain, that's somebody I think we should be not just getting a CT scan on, or if the range of motion doesn't exacerbate that pain, then that's somebody I think we should avoid a CT scan and just assume that it's a muscular etiology, because that's a common thing. Everybody's got whiplash after a motor vehicle accident, but we don't need to be getting a CT scan on every kid that comes in with a little bit of neck pain.
Okay, good. Thank you. So for want of time, I think we will press on for the next patient. So our next patient is a 3-year-old male child, had a history of road traffic accident 1 hour back, inability to move both lower limbs, loss of bladder, control, and diffuse tenderness over the thoracic spine. So I think this is there is no big brainers for the diagnosis. So this is a very small child, with neurological deficit, and this is the radiology. So essentially normal, particularly, I mean, can I ask, Vijay, what would you look for in a patient like this when you're looking at a... This is a 3-year-old child, complete neurological deficit below thoracic level.
What level, sir? Clinically, what level?
High thoracic, T4, yeah.
Any widening of the pedicles on the AP view? Any?
Yeah. So for the people on the course, I think the most important things to see in the neck, you see for soft tissues, enlargement of the soft tissue space, widening. But in thoracic picture like this, you have to look for widening of the pedicles. Then on the wedging of the vertebra on the lateral views, and also for any telltale widening of the interspinous process or a fracture of the spinous process. So all these will be telltale signs of deficit, which none of which are present here. And this is the CT again, which shows that there is no evidence of any fracture. Everything looks completely normal. And absolutely any patient with a neurological deficit has to have an immediate MRI, and you can see the MRI over here, which has a large signal intensity or spread over 2 or 3 areas. So this fits in the typical description of severe spinal cord injury without any radiological evidence. So this was a big problem in the time where MRI was not there. As the previous 2 speakers said, diagnosis and the pinpoint of this entity is not a big thing after MRI. But I would like to ask people now, in our case, we also did a diffusion tensor imaging. And it's not of particular interest in this patient because we can already see a lot of changes in the normal MRI. But when you do a diffusion tensor imaging in a patient who has got a cord contusion without major changes obvious in the normal T1 and T2, you can still see a disruption in the continuity, and that's very, very useful. So I would ask the panel, because the diagnosis is not a problem here. I'll start with Patrick. Patrick, in your experience, what is patients' parents are aghast when this happens, and the first thing they ask is, what is the chance for recovery? So what is your experience on severe recovery?
Yes. So if the child is still in spinal shock, we can't say what the prognosis is until spinal shock is over. If spinal shock is over and the patient has a complete deficit, then unfortunately the prognosis is dire. Very low chance, less than 5% chance of any meaningful recovery below the injury. If there is an incomplete injury where, even if it's an Asia B, where there's maybe some sensation or pressure sensation below the injury, then I would say with a pediatric patient, we don't know, but there is very good potential for some level of recovery. And again, we don't know what the time frame would be. It could be hours to months to years before we see the full extent of the recovery, and it may not be a complete recovery. But so those are the things I would say. In terms of role of surgery, probably not much of a role for surgery. There's nothing compressing the spinal cord. It's really just a contusion that's already happened. And then steroids, as I said, not great evidence for use in pediatrics. Even the evidence for adults are weak, but due to the fact that there's a lot of malpractice in lawyers in the United States, we usually use it. And late sequelae are the same as anybody with a spinal cord injury.
So any differing opinion, or anybody wants to add something? And in particular, I would like to ask the panel, does anybody use steroid? Obviously, Patrick talked about a medical legal influence on your decision. That's not a big issue in India. So Vishal, Vijay, Arjun, Sarang, Dr. Ramani sir, how many of you use steroids?
Within 8 hours, sir, I'll use it.
I would use it if the child came in early.
Within 8 hours. After that, I won't use it.
Just Because I
I
have,
would-
quite
I would-
frankly, sir, there's nothing else to offer for the child. So
Exactly.
might as well try the steroids and then see what happens.
At the same time,
But
both the
Vijay,
point-
that's not an argument that I would use something because there is nothing else to use.
No, in the sense that it can.
But with so much, I'm just, because this is something very important because steroids is overused, and with the 8% high complication rate of using steroids, in India especially, still people start using steroids even after 8 hours. So that's why I just want to highlight and spend a few minutes on this.
If the child came in early, I would use the steroids, not late.
But there's no proof that at a thoracic level there is any benefit. There is a proof that there is a mild benefit of an improvement between 3 to 6 weeks in a cervical lesion, but there is no proof that steroids are useful in a thoracic lesion. So why would you use it?
There are plenty papers on this, plenty. The two very specific markers of poor prognosis with no motor recovery in Skivora is one, delayed presentation, complete loss of motor and sensory deficit, and third is presence of intraneural signal changes. This child, though, has come early, but I think presence of intraneural changes and complete injury, if spinal shock is over and still remains complete, I think it has extremely low chances of any recovery, even with steroids. Even if it comes early, the chances of recovery are very poor.
Okay. So the recovery potential is low, and some of these children develop a small deformity over a period of time. So the other thing is that these patients must be watched over a period of time, and some sort of spinal stabilization may be required at a later period of time.
So I think
go on, please.
One more thing I'd like to just add is, there's a role of an interval MRI for these patients.
Exactly.
To see what's happening subsequently. Is there any hematomelia? Because as the methemoglobin accumulates, what happens on the interval MRI, that's sort of one thing that's important. I think the other thing is, just a learning point, the CT, rather than seeing the films, I think it's very important to look at the scrollable images, so that you don't miss like a ligament or a, sort of cartilage injury, which is going through all the three columns, like a chance sort of injury, which you may miss on a, static film, I think. So.
In fact, like Arjun rightly mentioned, there is a significant evidence that interval MRI done at 4 weeks interval after the primary injury have picked up in almost 11% cases definable instability, which will require surgical intervention. So I'm not sure how much relevance that carries. That 11% kids may show significant instability, which will require surgical stabilization on an interval MRI done at 4 weeks time. Dr. Patrick, Dr. Raja, your point.
So Arjun, you are talking of an interval MRI for instability or for cord changes?
For the cord changes. For the cord changes, sir.
But would that
for the neurological sort of to sort of prognosticate, because if there's a bad hematomelia and stuff, then it's a bad prognosis. You can
presence of T2 signals at between 1 and 2 weeks indicates it's a dense neurological deficit, probably complete, and that
so a progressive,
yes,
right,
and so fresh MRI changes and
right, there is evidence that if those changes are not present, then the patient will, we should expect full recovery, as we all know.
Okay. I mean, I didn't catch you properly. So if there are no evidences, but still if the patient is ASIA, would that change the prognosis at 4 weeks?
No, I was talking it more about between 1 and 2 weeks, where the...
Okay. Yeah, okay, good. So this is something that we see rarely, but it's a very important thing that we have a very clear concept. And the third case is a 6-year-old boy. History of a trivial fall, complaints of pain in the neck, came walking to casualty, neurology normal, no other injuries. And perhaps this is something what Vishal and Arjun were talking about. Small children complaining of a lot of neck pain with restriction of movements, and we should not miss an injury. So you can see here, this is the Anything, Vishal?
Only the
Nothing
ADI,
dramatic.
I would like to measure that. I mean, there is some soft tissue at ADI level, and probably
Oh,
the
yeah?
ADI is little increased. Maybe that's what the only thing that I can see. Though in kids, it may be normal to up to 5 to 6 mm, but this looks little more than 6 mm. The atlantodense
Yeah.
interval.
Okay.
And soft tissue
Good.
shadow there is little prominent.
Little bit problematic. Anybody else? I mean, that's exactly. There is no red herring over here, no catch point. So that was the only suspicion. And in these cases, as we already discussed, the threshold for taking an MRI must be really very low. And this is the picture over here. And as you can see that there is a small fracture in the odontoid. So young child, 6 years old, and odontoid fracture. So Sarang is here?
Right.
Yeah, Sarang, how do you proceed on this? Okay, if we have some issues, Vijay?
So I've treated small children. I've treated a 3-year-old kid and a slightly older kid, both of them with this similar case in a hanging head cast in those days when I used to put a Minerva cast. But this, I think, no neurological deficit. I'll put a halo and treat this child.
I would get an MRI, sir.
MRI, of course, but then I'd put a halo and also treat this child.
Yeah, MRI did not show any particular additional issues. Patrick and Viral, you have something more to add? What do you do?
I think one of the debates here is what's the best immobilization? Is it a collar? Is it a Minerva cast or a halo? I think the Minerva cast and the halo, the family can't take it off. Neither can the child. So that would be my preference more so than a collar. Also, if the child becomes uncomfortable, you can always then keep them in the halo maybe for 6 weeks and then the collar for another 4 to 6 weeks and sort of kind of slowly back off of immobilization rather than if you start with a collar. So that would be the only point I would make here.
So there's a fairly good consensus here because it's not a very displaced fracture and it looks no other major ligamentous injury, then it's fine. But for the course and for teaching purpose, it's just that whenever you see this, you need to be careful to identify whether it's a fracture or it is an os odontoideum or it is just an ossiculum terminate. So in Patrick's great lecture, there was this slide which was actually showing the ossification centers and how you should be looking at it. So this is the picture. You can see that this is the 3 types. Type 1, which is very rare. In children, it's an actual avulsion injury of the alar ligament. And the differential diagnosis there must be whether it is a persistent ossiculum terminate. The defining points will be that it is got a very well-defined smooth corticated margins, and there is a typical V-shaped cleft over here. So these are the 2 things: a very well smooth margin and a V-shaped cleft, which will actually give clue that it is a persistent ossiculum terminate. So that you should be. Whereas if it is an avulsion, you can see that there is a sharp margins and you can get the typical appearance of a fracture over there. Type 2 is most common and may occur through, again, you need to be careful that you are not mistaking it for the synchondrosis between the dens and the body of C2. And at this level, you should also differentiate it from os odontoideum. Then again, the clue is that in os odontoideum, it has a smooth corticated margins. And generally, you have a hypertrophied anterior arch of C1 also, and relatively foreshortened the base of the dens. There are 2 types, which can be, that's a radiological differentiation. So here it is a very classical fracture. And as everybody in the faculty mentioned, conservative is the important part of this. So how often, Patrick, do you need to operate on these children? In children, when do you have actually operate?
That's a great question. Almost never when I see os odontoideum is it somebody that I saw at the time of the original injury. And most of the patients that have it can't even recall what the inciting injury was years ago and things like that, whatever the fall was. So, so if somebody like this that you're catching early, it's a new fracture radiographically and by history. I feel like there's a very high chance that this is going to heal and not go on to an os. So I can't give you any insight or percentages as to how many will go on to a non-union with instability. I don't know, what's your experience?
No, I think what you say is true. I mean, if they are properly immobilized, they go. I was just going to ask the same question to the faculty. Has anyone had an experience of these kinds of injuries going into a non-union?
I think at 2 months, it's once the child is out of the collar, it's a good idea to get a flexion extension film just to sort of rule out instability, so that you're
of course, that will be a standard.
I would do that at 2 months and then take a call, because that would be the way to decide.
More than non-union, I think in kids, malunion is a problem when they are neglected or they are not mobilized rigidly in the early phase of their fracture. I think they really tend to go into malunion, and we have had cases where they have really angulated quite badly there. So that is one thing that has come to us in our experience.
And the other thing is in India, because in India, sort of India specific, one has to keep in mind, sort of CBJ Cox, because there can be some destruction of the odontoid C1, C2 joint, and an MRI sort of would help to differentiate a pathological thing, especially if it's a very trivial fall. You're not sure, it's just good to know, because sometimes you'll pick it up. So, I don't know.
Yeah. So this is this is for teaching purpose. This os odontoideum can be theoretically congenital versus traumatic. But what is very obvious here is you can see that it's not fresh. So you can see that it is completely smoothened out, and you can see the foreshortened base of the dents, and there is some instability. So you divide this, classify this, whether it moves along with the C1 or whether it has a separate mobility. So if you find that it has gone on to the stage of os odontoideum, then of course then you require surgery. There is no other option for surgery, and then your standard will be to do a C1, C2. If for any reason you find that you're not able to have correct purchases, then you can go on to C3. But the standard treatment is C1, C2. So is there any other points that any of the faculty member would like to make on this? Otherwise, we have overshot time by clear 30 minutes. And Theddy is waiting for her. We're all waiting for his oration.
I think like children with os odontoideum, with syndromes, sort of one should keep in mind Down syndrome, etc. And some of the mucopolysaccharidosis, they will have an associated or sometimes, and that can lead to neurological deterioration. So in a pediatric practice, it's important to look for it in the clinic. Just look for this. When you're screening, especially if you're going to do any extremity surgeries, just get a flexion extension film before, so that you've kind of ruled it out before you. Otherwise, you can have a problem during intubation and post-operatively. So it's better to screen before.
Yeah, absolutely. So Taral and Sandeep, I have not been keeping a watch on the chat box for questions. If there are any questions, you can just prompt it up and we can ask the faculty to respond.
Most of them have been answered by individual people.
Okay, that's excellent.
I don't think there is anything pending. So thank you very much, Dr. Rajshekharan, for those excellent cases.
Okay, thank you for everybody. Patrick, Viral, and all the Indian faculty, thank you very much. It was a pleasure to have all of you.
Thank you.
Thank you, sir.
So now we are going to one of the most interesting and last session of the IFICS 2020 web conference, and I would invite Dr. Dhiren Bhai to share his screen. Taral, Dr. Dhiren Bhai will be introducing our speaker of the day, Dr. Theddy Slongo. I would invite President of the posse, Dr. Dhiren Bhai, to introduce our orator.
Good evening and welcome to the most interesting session of this whole IFICS event. And today we have IFICS 2020 oration by a very eminent Professor Theddy Slongo. He's a senior consultant of pediatric trauma and orthopedics at University Children's Hospital of Ben. Actually, Professor Slongo does not need any introduction, but just for those who are like new to this field, he has a vast experience of 44 years. And he's the person who devised two important implants, titanium elastic nails and pediatric hip locking compression plate. And for these two big innovations, he got the AO Innovation Award also. He's a founder of AO Pediatric Expert Group and also a chairman of AO External Fixator Expert Group. Now almost on the verge of retirement, he's spending most of his time for training the young doctors about teaching about the trauma. He's a very keen and very dedicated teacher, and those who have attended the AO course, they are like familiar with his dedication and commitment to the teaching. Today he's going to speak on his very favorite topic, 37 years of experience with elastic stable intramedullary nailing. Where do we make mistakes and why do we make mistake? So with that, I request Professor Slongo to give his oration. Thank you.
Thank you very much for this introduction. It's really a big honor for me to share this time with you. I followed over this month all weekend your sessions, and this is really for me an important thing to say that this was a really fantastic event you organized here in India, and really I'm very proud to be a part of your session. Just a moment, I will open. Okay, it's okay. Can you see the screen?
Yes, yes, Doctor.
Okay, so again, it's really a pleasure to be with you and to spend this last session with you about elastic nailing for children's fracture. Over the last 4 weekends, you know, we heard nearly a lot about all the fractures, nearly all segments around the children's body. We discussed cases. And as you know, even for India, more and more, the elastic nailing gets more and more popular to stabilize long bone fractures. I have, in the meantime, some numbers from the companies that unbelievable, nearly 1 million children a year are treated with elastic nails, nearly 1 million kids with elastic nails. And what I see, and therefore I am very happy to give this talk, I see that during this long period now, nearly 4 decades, we see more and more failures. And the reason for this, that more and more young surgeons, but especially also, sorry for that, adult trauma surgeons, they believe, oh, this is so simple to stick 2 nails in the bone, and then why I have to go to learn this in a course or to read the textbook or an OP technique. And therefore, especially in this situation, we see a lot of complication. So my goal today is a little bit to speak of my experience about failures. So what are the learning objectives? At the end of my presentation, you should be able to identify those fractures which are suitable for ESIN. That means indications. And for me, this is the key step, the indication. Even in our clinic, very often we see that the elastic nail is used in the wrong indication. And this is not the failure of the implant, this is the failure of the surgeon. And you should be able to describe the most important biomechanical principles for the safe and stable fixation. That means this famous 3-point contact rule. And recognize technical failures that cause complications. And that you can list the most frequent failures. Describe how stability can be ensured or increased in critical situations. These famous end caps we developed, and outline the technique, how and when to use end caps, and explain the most frequent problems. So this presentation is based on my own 37-year experience using this technique, focusing on correct technique, because we start with this, surgical mistakes, problem and complication, pitfalls, and pearls. So here again, a little bit history. You know, on the left side, Jean-Paul Métesson, who is the godfather of this technique, started in Nancy in 1982 and 3, and had the luck at the same year to make the first course ever in the world about elastic nailing. And since this time, I'm familiar with this. And as you heard before, in the meantime, I invested much time to develop this technique and teach this technique around the world. And you see also a picture here with Kay Wilkins. He was also a part of our team at the beginning. What was done over the last 37 years, as you can see here? During these 37 years, we have offered a large number of courses, especially on the part of the AO, including a manual. I myself made more than 180 courses worldwide, even in India. So first of all, what it means ESIN, and it's important that we always remember this. This is a short name, elastic, stable, intermediate nailing. It's a minimal invasive and minimal traumatic, it should be. Sufficient stable for movement partial with bearing, biological and child-friendly osteosynthesis for transverse, oblique, and short spinal fractures. With these titanium elastic nails 10, but you can do this also with stainless steel nails as well. Where the ESIN can be used, but always recognize the 3-point contact. I will show you this later. Of course, the most popular are the femur fractures, but not the femur fracture are the most frequent. As you know, the forearm fracture are, in the meantime, the most frequent fractures we stabilize with elastic nailing. But of course, you can do this also in the lower limb as the tibia, as well in the humerus. And always we use this typical technique. Then we have some variation in this monolateral technique for more distal fractures in the femur, more proximal fracture in the humerus, or more distal fractures in the humerus as well. And as you know, also for radial neck fractures. Over all this time, I have analyzed what are the most important key steps to avoid complications. And even in our clinic, when I discussed with the young colleagues why this happens and why this is not correct, I see that they made no clear planning. Again, it seems to be a simple operation, so an easy operation, that the most of them said, oh, why I should do a planning. I remember my first orthopedic teacher was the famous founder of AO, Moritz Müller. And at this time, 44 years ago, when we treat a fracture, we had to make drawings, a plan. And in the next morning, if a screw was not placed where we had planned it, you get in trouble to explain this. And even here for the elastic nailing, it needs a plan. But these are only a small step. First of all, the choice of the nail, the thickness of the nail is 1/3 to 40% of the narrowest medullary canal. Insertion of the nail 1 or 2 centimeters away from the growth plate, respect this, and the pre-bending for a biomechanical purpose. The second step of the operation planning is in which direction I should go with my nails. That means I have to analyze my fracture, the morphology, the location, the level, the segment of the fracture. I will show this later. Then a lot of people say elastic nailing is not rotational stable, but the rotational failure is made by the surgeon. How you can avoid it? Rotation control of the non-fractured side. That means in our hand, for complex fracture, comminuted fracture, I sterilize both legs that I can compare the rotation during my operation. The position of the child, orthopedic table, yes or not, this depends on your experience. As you can see here, here you have the orthopedic table on the left side, but you know, this is problematic in the fracture table to check the rotation, and it needs a lot of preparation. My preferable fixation is the free position of the child with a towel around the unfractured side, and I can pull on the leg and I have a free view to the whole leg. There is another trick. This is from Uni Narayan. I made together with him also an education event, and this is slides from him. He gives a pillow under the hip, and this gives some internal rotation, and this gives him also a free access to the leg. But anyway, you have to stabilize the child in for a femur. Of course, for a forearm or lower leg is different. The scientific basic, what we have to know, and always to remember for every operation, never forget this during the operation. Symmetrical bracing of two elastic nails, as you can see here. It's like a parallelogram inside in the medullary canal. And as longer the inner contact of the nails to the cortex is, as more stability you get. And therefore, then you have 2 times 3-point fixation, as you can see here. And this is also a very nice presentation we had together with Uni Narayan. You see what is the effect. You have your nail, you prevent your nail. In the first step, when you insert one nail, what happens? Of course, because of the pre-bending, the bone goes in this direction. And if you insert a second nail of the same diameter, same pre-bending, this equalizes the force, and then the bone gets straight. And so you have your 6 contacts. And this you have to keep in your mind during every operation, even you make you 500 or 1,000 operations. What you should never forget, you know, this is not a rigid implant. This is an elastic implant, and that we have a double frame model. The best bone is really the femur. Why? The femur has muscle envelope around the bone. And for the elastic nail, this is an action between the elastic nail, the elasticity of the nail, and the muscle contraction. If you look here on the right hand side, in the lower leg, you see the bone, the tibia is absolutely asymmetric, and the muscle is behind. So therefore, we will see this later, this is a much more problematic situation. Here you see a short video animation, how it works. The memory effect in the nail brings the bone always back to the proper position if you have a correct construct. And you see it also for for oblique fracture. During the muscle contraction, it goes a little bit apart, and then the elasticity brings it back. And the same here for rotation stability. This is the memory of the titanium elastic nail, that you have a good stability and alignment of the fracture. So the plumbing, less problems. Again, I mentioned this before, nail diameter is crucial. Then again, here I made some analysis about the nail diameter and the medullary canal. You know, a very young child under 8 or 10 has a normal bone, but the medullary canal is very wide. So in the area, very young child, it's very problematic to use the elastic nail. What is then the problem in a teenager? A teenager has a very, very strong bone, and the outer diameter is the same as a 10-year-old, but the inner diameter, that means the medullary canal, is very narrow. Therefore, this is a problematic situation. You have not a good spreading. In elderly patient, we never use it in elderly patient, but you see, we have a wide medullary canal, so the nails are apart in a wide say, and this gives not a good stability. So this age group has the best stability when you have 1/3 of the nail diameter. What is also crucial, I mentioned before, is the rotation control. Before you fix the nail in the forearm, in the humerus, in the lower leg, in the femur, I show here in the femur, you should check the rotation. This should be symmetric to the other side, or at least symmetrical inside-outside. And once this is symmetrically, you advance the nail in the metaphyseal part, distally or proximally, and then the rotation is fixed. Again, rotational failure is a failure of the surgeon. What is important, especially in the femur, check the proximal nail anchorage in axial view. I know from a lot of colleagues, they are not able to control axial view during the operation. And then they are surprised later on when they get x-rays that the nail are not correct position. Look at this picture here. In the middle here, the nail looks not bad, but when you look very carefully, you see, okay, this is the border of the bone and the nail is a little bit out of the border, but this colleague did not recognize it. And then, of course, when you make a better view, this is the situation. This is the same patient. You know, you see this because of this clamps here, and this is the situation. You should avoid this, and you can avoid this when you go in an axial view. The other point is, for all fracture, you should check your axial stability. And in the femur, as you can see here, once you have finished your operation, you should push very strong against the knee, or you should push also against the hand. And you should test then if the nails migrates outside or not. If it comes out, you have to do the operation again. This is the situation in an unstable situation. This happens when the patient awake from the anesthesia and the muscle contractions start, but this is too late because then the patient is out of the OR and you get in troubles with the patient and the parents and the situation. So here you see an example how it looks correct. Good spreading, correct level, good alignment. It should be always like this. And I can tell you, in my clinic, when I was chief there, I did accept only this situation. If it was not in this situation, we had to go for revision. So we have to discuss about what are complications. In principle, we distinguish a little bit between real complications and problems. Of course, a complication is an X-ray we don't like to see. That means a malalignment. A loss of reduction is a complication. Delayed healing is a complication. You have to think about why. Malunion is a complication. Bad results concerning function or appearance, especially in the forearm, is a complication. If you have to go for reoperation, this is a complication. Infection is a complication. Skin irritation at the entry site, in the meantime, that it's not a complication, it's more a problem, because once the nail is removed, the skin irritation is over. But you see, there are a lot of complications. So we made a long time ago in Europe, 4 clinics, we made the survey 25, 30 years ago. We analyzed 405 femurs. You see the forearm numbers, nearly 1,000 fractures. And we checked this. We distinguished intraoperative problems. Of course, if you recognize the problem intraoperatively, you can solve the problem. The problem is if you do not recognize the problem and the patient goes out of the OR and then you see it. That means changing to open reduction. We have seen this in this series 50 times, this 5%. In the meantime, we could reduce this number because of a better evaluation of the fracture. But this is not really a complication. It is much better to open the fracture over the fracture zone and make the reduction by finger after 20 minutes or 5 attempts than trying 1 hour, 2 hours with 10 minutes of irradiation to bring the nails through the fracture. Nail perforation at the femur, you will see such a case. This is a real complication because you make a stable fracture to an unstable. And the iatrogenic fragment as well. Intraoperative problems, you see the skin irritation is not intraoperative, but came from the intraoperative. Skin perforation came also from the intraoperative problem because you will see 2 long nails. All this are problems. Overall, we have these problems. In the meantime, I can tell you, over the last 10 years, we could reduce this below 1%, because all these points, as you can see here, are in your hand. These are all points the surgeon has in his hand. And now the real complication in the long term, delayed healing, non-union osteomyelitis, you see, there are very, very low numbers. But even this number, you can bring it down. This is a work from a Toronto experience, early experience. In the meantime, they have less complications. Pain or prominent insertion site, you see, this is the majority. But this is really a point you can avoid 100% if you will take care on this, as I will show later on. So as surgeon, there is no other surgical method which forgives technical mistakes as much as in. And this is a little bit the problem. Very often colleagues tell me, hey, Dr. Slongo, why you are so critical? Look, it heals well. But then I say, okay, in the next situation, if you make the same failure again and the fracture is not so stable, you will end up in a disaster. So therefore, some bad examples can still end in good results. And this is not the goal. But this is not an excuse for not doing it in the correct way. So here are some pearls again. So only to remember, what is the goal? The goal is that we get such an alignment, such a fixation. Here you see a long spiral fracture. Even a long spiral fracture can manage in a good way, good alignment, if you have a correct biomechanical situation. So therefore, I mentioned this before, the first key step when we start to do ESIN is the indication and limitation. We have to know what are the limitation and the indication. You know the sentence, if you have a hammer, the whole world looks like a nail. Or if you have a hammer, you can use a nail. No, this is not correct. Even in our clinic, I have to say, be careful. You know, please analyze the situation. And we have three factors. Of course, we have the patient. We have to look at the patient. That means the age, year, bone morphology, as I mentioned before with this model. You have to look at the weight of the patient. And remember the slide with the medullary canal diameter. This is important. Then we have to analyze the fracture. Fracture, segment, site, morphology, severity, stability. And don't forget the surgeon, his experience, correctly planned and executed. So when we go back to the patient-related factors are age. We currently accept age from 3 in the meantime to 13, 14 years of life, depending on the body weight. We know in some region of the world, a 10-year-old child can be very big. And as I have shown before, please analyze the medullary canal diameter. If such a child, as you can see here, have a medullary canal only of 8 or 9 millimeter, you know you cannot insert a 4 millimeter nail. So this is not the indication for an elastic nail. The weight, upper limit up between 50 and 60 kilograms, lower limit is set by the age. And you have to look at comorbidity, neuromuscular disease, pathological bone. So these are the factors you have to analyze. Every time in the fracture-related factors, the morphology of the fracture, of course, length unstable, is the fracture proximal or distal, in the forearm, in the upper extremity, in the femur, or in the tibia. Depends on the bone, but please analyze this. This is important. Normally, we distinguish between 3 segments: proximal, middle third, distal third. And now we came to the most important factor. This is the surgeon-related factor: fracture assessment, influence indication for ESIN, planning, poor quality imaging. You know, sometimes I'm really astonished on which bad X-rays the decision is taken. Risk of malunion, non-union. Malunion is more commonly seen due to poor technique rather than the fracture morphology. That means poor technique means surgeon. Non-union is only seen as a consequence of a poor technique or patient selection. That means indication. So this is the hands. So therefore now we have to discuss how to avoid complication again, that we do not see this. So why we see such problems? In our experience again, and I have to focus on this, the most important factor for a good or bad outcome is the surgeon's performance. You know, this is the surgeon. You are the worker, okay? How can I do better in the next case? I think we have to analyze this. Sometimes, especially in a presentation, I see a presentation over 20 minutes showing 10, 15 cases, and every case has a failure. And why a surgeon can make this in this way and do not correct his technique? Because he never did a course. So the problem has a face, and this is for the most part of the face of the surgeon. I know it's a very hard word. So our statement, the 10 is a simple implant, and it's surgical expertise that determines the quality of the reduction and stability of fixation, the technique. Therefore, it is essential to understand the mechanical properties of the material 10 or stent or SE method. So complication of the femur, let's start with the femur. This is what can happen. I have shown this before, third fragment. You see, this is a normal transverse fracture, and now it's an unstable fracture. Why this happens? The reason is the surgeon did not recognize that the tip of the nail sticks here in the fracture, and then he was using the hammer and create the fragment. Or you see this, as you have seen before, the surgeon was not able to check the axial view, and you see, okay, here you see it's fantastic alignment, but this patient had a sciatic nerve damage, you know, this can happen. Or wrong technique, no 3-point contact, young patient, crossing point on the fracture side, this is not stable. Or as you have seen here, comminuted fracture, not stable enough after anesthesia, when the patient wake up, then collapse of the fracture. So this is what happens, and we can avoid this. So we say avoidable complication, which should be identified and correct. You see, this, what you see here, you can identify this during your operation and not at the end. You have to look in the AP and lateral view, and then you will recognize it, and then you can correct it, okay? So this here is also mechanical principles are neglected. This is no good fixation, crossing point here, and more. Technical failure, again, the proximal. Using the hammer this is the problem. No axial view, and here you see the trick. If you fix the patient in this way, okay, then you can see the axial view here under intensifier when you rotate the leg or rotate the intensifier. Sciatic nerve damage is possible, and we have seen this, and they are reported. Here you see again the correct view. This is the model, and if you have under intensifier a good local axial view, then you see that your nail is going up in the correct way. So here you see the position of the C-arm. There are two positions. You can have the position in an AP view, or you can have the position in this way. Both are possible, depends on your preference. Here you see from our workshop together with Uni Nayaran to show you how this happens. You see, the first nail, the medial nail, is going up to the metaphysis. And we have to take care that the tip is always in the middle part of the bone. If you rotate the nail anterior, you see it comes out. And this can happen even on the greater trochanter. So you have to rotate your nail tip in the correct way. On the lateral view, you can see this. And for the lateral nail, it's not so important. But the medial nail, as you can see here, he can come out here. You will not see this in an AP view. You can see this only when you rotate. And when you are hammering, as I do it now, here, then you will see what happens. You see, the nail comes out. Why? You see, the nail goes always backwards. The medial nail goes always backwards. Therefore, you have to rotate, as you can see here, the nail tip anterior, and then you have to check it under intensifier that the nail tip is well orientated, as you can see here. You see this, and then you can advance the nail. And then you see it goes up here in this way. Okay, then you are over the calcar and in the correct position. So here you can avoid this problem. This is what you have seen. Other case, this is another case. It is okay. Then failure, unrecognized failure, nail diameter. Remember, 30 to 40% of the nail diameter. So here you see the failures. The nails are too thin, crossing point 3 times. The patient was after the first day post-operative, he came out of the bed, and this happens. In this situation, back to the OR, anesthesia, and the hip spica. But this is not what we want to see or we want to have. No, we will have a good stability. So these are the wrong nail diameters. Look at this picture again. This is the same. We have 3 very bad situations. We have a corkscrew phenomenon. You will see this later. This gives no stability. You see we have no contact to the cortex and too thin nail. Solution. You have to recognize the failure. Be honest with yourself that if you have such situation, restart. Go back, pull the nail out, and redo it. Consult operative technique or tech box. Document failure and plan revision. Discuss with a colleague. Seek the assistance of a colleague. Revise the procedure to make it better, as I mentioned before. Again, you see here, technical failure. It looks not bad, but it's unstable and you end up in an imbalance. The other problem here is you see the nail diameter. This nail is thicker than this nail. And this gives not a symmetrical bracing as we need. So this is the problem here in the video. You see here, we have a 3 millimeter. This is the golden one. And the second one is a 2.5 millimeter. And remember my presentation before, you see what happens. It's clear it's very difficult to simulate this in a model because we have no model, no muscle around, but I can simulate this. You see here now, we have 2 different nails diameter. Even we have a good spreading. You see, the golden nail is stronger than the green nail, and this brings you the situation in a varus or valgus. You see, this is not neutral, as you can see here. So this is the failure, and this happens. Okay. Then the third fragment, as you have seen before, if the nail sticks here and you start now with your hammer, you can break out here a fragment. And then a stable fracture gets in an unstable fracture. So be careful that the nail follows your medullary canal. That means you have to rotate the nail tip in a correct way that he follows the medullary canal. Okay. Then the other problem we have seen is skin irritation. And the skin irritation is completely in your hand. It depends how you cut your nail. You see here, you insert the nails are here, and then, of course, it comes inside here. And what is important, that you recognize that one nail does not cross the first nail twice. This creates the corkscrew phenomenon. So therefore, you have to recognize, I will show this in this video, and you can check this under intensifier, if your second nail is in front or behind the first one. You can see this. Now I advanced one nail, you see. You see here now, this nail is over this nail. So I advance now the nail forward up to here. You will see to the fracture side. Okay, so you see here, the nail goes by hand. I do this always by hand, by oscillating maneuver, as you can see here. The nail follows, and now this must be in plane, as you see, and then the nail can follow up here. The second one is following here. And here Uni explains, if the nail does not pass the fracture site in an easy way, you have to rotate the nail tip that he can pass through, go over the fracture site, as you can see here. Okay. And now the next nail is coming up. That here you create the fragment. You see, when you stick here and you start to hammer, then you create the fragment. Okay. So this is also important now for the nail insertion, as you can see here. So this is now how to avoid the corkscrew phenomenon. So the next nail is going up now. So you can rotate the nail and you see the tip takes the first nail away or not away. Then you move it, you see? And this creates a corkscrew. You should avoid this and you should recognize this under intensifier. So check under intensifier in which position is your second nail. So you can avoid this, huh? Okay, good. Again, other example you see of wrong a segment. This is a distal segment. It should be not do in this way with or this is a distal comminuted fracture, anterograde, retrograde nailing, unstable, this happens, or that we have seen before with the corkscrew. Okay, what is the problem here? No bone contact, you see no bone contact here, no bone contact here, it's unstable, it's a floating fragment. Or here, it's longitudinal unstable, wedge, crossing point here, spreading is here, cannot be stable enough, wrong technique, or as you can see here. You see, these are the failures you can avoid. These are failures in your hand. This is what we mentioned before, you know, in the investigation or the early results of the Toronto clinic, they had 42 cases with skin irritation, and the skin irritation is coming from wrong lengths or wrong bending, and all this is wrong. And again, all this you can avoid. But this is not more a complication, this is for us a problem. Once the nail is removed, the problem is away. So this is not good in this way. So I show you here how we do this. So we cut the nail. We do not bend it a lot, only for cutting. And what is important is that the end of the nail is below the fascia. That means that if this is the fascia, the nail must be under the fascia. And how you can identify this? If the patient is able to bend the knee, or you are able to bend the knee of the patient, then it's okay. If the patient during the operation cannot bend the nail are too long. A good instrument is this beveled impactor. This beveled impactor has a hole inside, as you can see, of 8 millimeters. So this guarantees that the length of the nail is always correct. This is always correct, and you bring it under the patient. Here again, the floating fragment, as I mentioned before, solution, revise with increasing prebending. You can use the same nail, but you should not leave it in this position, okay? Distal fragment is not fixed by the nail. Again, what is the problem here? This is a long spiral fracture. It's a young patient. You see, this has nothing to do with nailing. These are only 2 implants in the medullary canal. but this has nothing, really nothing, 0% to do with stable elastic nailing. This is, I saw mostly, this is fracture manipulation with internal decoration, not more. This is only a decoration, not more. Okay, so here you can solve the problem. So in the meantime now, we have an option to avoid this telescoping. We know tell this telescoping in this comminuted fracture. This is the end cap. And this is a very simple implant. You can put it over the end of the nail. It's a self-cutting cancel bone screw, and it's also smooth and protects also the skin. You see here a very, very severe comminuted fracture, 5 fragments. I treated this in a perfect way, good spreading and end caps. And you see here a long inner side and a fantastic alignment and healing. Even such fracture with the correct technique and the implant, you can treat it. Here we see again the example. Nowadays, in the most long spiral fracture, we are using end caps. Here with the beveled impactor, we bring the nails to the correct length, and then with this inserter, it's a simple instrument, the inserter, we fix the end caps over the bone. And here you see again the perfect result. We, of course, we tested this in the cadaver lab as well in bone models. And you see here the conclusion of our investigation. Force at failure is significantly higher when end caps is compared to the solution without end caps here in the bone model. And this is the result. We could load up to 300 kilograms with end caps in a healthy bone. So here you see how we do it. With the beveled impactor, we go to the correct length. So this is important. Here I'm using the hammer. Then you need only this inserter. The end cap is the screwdriver and the end cap. You bring the screwdriver over the inserter, T-handle or whatever. You see, you have to open it. You have to not too brittle. And this takes 1 minute, not more. And then you go over this and you insert the end caps and you get this axial stability. The end caps are only for axial stability. And what is important, never, really, never use end caps for transverse fracture. In a transverse fracture, you can create non-union because the fracture is not able to collapse, okay? So here you see other examples of failures, twisting the nails, corkscrew phenomenon, lead instability and malalignment. You know, you should not accept this. Okay, you can avoid this. You during the operation, you see all this, okay? Or this, you see, this is terrible situation. Never do this in this way or in this way you have seen, or you damage the vessel or the nerve. And again, here, sciatic nerve, it's a problem. So when we look from the surgeon side, we have some, but very seldom, unavoidable complication, infection. But is an infection really unavoidable? This is a question. But in principle, there are non-unavoidable complications, but we know infection and entry site, as in the middle can, is always possible. Even in our clinic, even in my hand, this is possible. So therefore, we have the question, preoperative antibiotics, yes or no? We, in our house, we give a single shot in all fractures. Redislocation or refracture because of non-compliance or further accidental injuries. We can see this patient, especially children, running around, make a new fall, and then they can have a bending of the nails or a delayed healing. Okay, these are the problem on the femur, especially. Now I came to the tibia. For the most of the people, the tibia looks as the most simple bone because you can palpate it. But the tibia, as I mentioned before, is in the body asymmetrical. All the muscles are behind the bone. And in the entry point side, it's a triangular shape. And you have to insert this from this point and this point. You know, normally we go on the same level, but here we have to go from here. And what happens then is that the nail goes always backwards. That means the nail goes in this way. Okay, we have to recognize this. So here you see some examples. Of course, the complication of the lower leg. And we know we have problems with isolated tibial fractures as well and complete fractures. In the isolated fractures, we have tendency to varus because of the spreading fibula and problem of the correct rotation. But here we see another problem. You see, we see a severe recurvatum, you know. So this is a problematic situation for elastic nail and not the best indication. And the recurvatum, and I will explain you, and you will see a video why this happens. Here, another example, you know, complete lower leg fracture, smaller tendency to varus, but it's an unstable situation. And therefore, it's also critical to use an elastic nail. Here, you see such an example. It looks not so bad, but you see here, the crossing point is here, and we see corkscrew phenomenon here, and you see what happens. Over the time, no bone contact, we have a gap, and over the time, a non-union. The only non-union I have seen around the world is in the tibia, and exactly in this situation. So the indication here was not correct. And if you take the indication here, you have to do the technically correct. And again, this is another problem, patient like this. Remember, in the femur, we have a muscle envelope, but in the tibia, the muscle is asymmetric. Here I show you other examples. What's the problem here? You see crossing point here, corkscrew phenomenon, delayed healing. Again, here, what happens in the tibia very easily, what I explained before in the video, is the corkscrew phenomenon, you know, and then you have no bone contact inside. You see it here again in the video. The problem, the nail goes always backwards, and this is a problem, you know. And here we see now, it's a wide medullary canal at the beginning, and you can create a corkscrew phenomenon very, very easily. So therefore, it's very difficult to fix the tibia in the correct way. You see here, you have to orientate the second nail in the good way. Remember which nail is behind, which nail is in front of the first one. And then again, you can create corkscrew. As you see here now, very nicely, the movement of the first nail, because I rotate the second nail in the wrong direction. So you have to go back. This is wrong. You see, this is the corkscrew. And you see the nail goes away from the cortex, has no contact to the cortex. Okay? So here, this is a big problem. And now the recurvatum is another problem in this way. Okay? You see here, this is the situation because the tip goes always anterior. And therefore you have to rotate the nail at the end posteriorly. This is important to know. Okay, so here again, you see tip are anteriorly, recurvation, because the nail goes backwards, opens here. So, and this is the entry point, not at the same level, and the tips are problematic. All these are failures, and you end up in a problem. Okay, so these again are the correct entry points. This is the correct orientation. And again, be careful not to create the recurvatum. This is cosmetically, especially in girls, very, very ugly. You know, this, so you have to do this, and then you have to rotate the nail that the tip looks backwards. Here you see it, again, the recurvatum. Here you see they are posterior. Very nicely you see it, and the tip goes to here. And now the second nail goes inside here as well. And so you have to rotate the nail in the correct way. So you see what Uni is explaining here, the orientation of the nail. So here another example of a failure, wrong indication, third fragment, unstable. Okay, this was the fracture before, and this is not the indication for elastic nails. The patient was treated in our clinic by a young colleague, so we made a revision, and then we were applying end caps, and you see, even with the end caps, we could align the fracture. Here another example, initially with end caps. Again, complications of the lower leg, recommendation for the lower leg fracture. The proximal part here is no indication. You see red, very bad. The middle part, I say, is not fantastic. I say it's good or optimal because we have a lot of problems. And also the distal part in the tibia is not a good indication. Now I came to the forearm problems. Here again, indication for active intervention, reduction and stabilization are displaced, unstable, both bone, Montecha, some greening, refractures. Be careful in the metaphyseal zone. You know, remember the square of the classification. This is a problematic zone, and especially this red zone is problematic for elastic nailing. So if you have a fracture in this zone, you must be an advanced nailer, or you have to go for another technique. Or if the fracture is on the level of the square here, you see, this is a problematic situation. As you can see in this example, this colleague did it with an elastic nail, but you see, this nail has never contact to the bone. The close peg on the rope, you see, this is the situation, and this happens. So this is not stable, and you have to correct this. On the other hand, especially in the forearm, in the meantime, we see such osteosynthesis and published as elastic nailing technique. But please, this osteosynthesis has nothing, really nothing to do with elastic nailing. This is again a Kirschner wire stick in the bone, or such a complete forearm fracture, both bones, only one nail and additional plaster cast. This makes no sense, absolutely no sense. This is a kind of child abuse. Okay, please never do this in this way. On the other side, there are many textbooks. They are published and with pictures with mistakes. Look at this picture. This is from a textbook. And look where the orientation of the hand. The hand is in supination and is the left hand. And you see the entry point of the nail. This is completely wrong. Even the proximal one goes through the nerve, you know? So these are the entry points you can read in the textbook. Even go never through the olecranon. This gives no stability. What is important, even in the forearm, each bone has one nail and we go with 3 times the diameter. So this is the way you bring it in, but then you have to rotate the nail as the tip, every tip looks to the membrane and makes a good spreading of the membrane. Nowadays, a new entry point is the Lister tubercle, but here we must be careful of the tendon. We have seen some rupture of the tendon, and so we have different nail insertion options in the forearm. So we can play a little bit depending on the fracture in this way, or in this way, or in the old way. And the disc is going in this way and in this way. And this is a big advantage. You can always work on the intensifier. But what is important, the end of the nail must remain over the retinaculum. Otherwise, he will rupture the tendon. Spreading is important in the forearm, that we do not lose the spreading. Here you see a good, it looks quite good, but look the entry point. This is bad, and the ulnar nerve that was not very happy. Sorry, go back, it was not very happy. So we made also some investigation about forearm fractures. We have seen such complication and problems, but in the meantime, I can tell you, we could eliminate all these problems because again, the problems are created by the surgeon. So I came to my conclusion over this long lecture. The ESIN represents the first option in the treatment of childlike shaft fractures today. To be able to make use of the full extensive possibilities, however, faults must be avoided, knowledge and practice. To avoid and know problems, some tricks must be mastered. It is fatal to trust only the childlike correction potency as the primary option and not to treat this in a correct way. Surgeon, what one should avoid. These complications are all in the hand of the realization of the surgeon. We say them homemade. The wrong assessment of the fracture and patient, use of the method for relative indications, the contraindication, technical failure, biomechanical properties are not respected, interruptive failure are not recognized or neglected. To our knowledge, the most important failure. To achieve this, the most important points are: we must perform and analyze quality control carefully and recognize technical failures interoperatively. Correct failures arising as a consequence of the suboptimal application of operative technique, using knowledge and expertise. If intraoperative recognition and correction is not achieved, it is undesirable to rely on modeling to restore anatomy as this risk. Long-term failures, delays restoration of function, especially in the forearm, eliminates benefit to the child with no improvement in outcome when compared to conservative management. And therefore, early revision of technical failures identified in the postoperative period should always be given serious consideration. I say thank you very much for your attention for this lecture, and I hope in the future you can fully use all the advantage of the elastic nail in the treatment of child's fractures. Thank you very much.
I think that was a great talk, Dr. Slongo. So thank you very much. And very nice points, important points about getting it right, and a lot of surgeon factors that would go into decision making, as well as recognizing mistakes and improvements. And this lecture is recorded, so we can always go back and listen to it and note down all the points in case we have missed, because there were so many important points that you made. So we'll open it up.
I would like Dr. Ramni to thank Dr. Slongo from IFICS side.
Let's just do some questions. Can we just do some questions before we end this?
Yeah, he will start the question answer.
Yeah.
Okay. Dr. Slongo, thank you very much. I'm Dr. Ramni Narasimhan. Good evening. And it is always a pleasure to listen to your presentation. And you always bring in something new, and that is what is the most important thing. Now, I'm just starting off the questions, putting some questions which have been put by the audience. So there is this question which says that how much would you contribute the medial penetration to the surgeon's technique, and how much to the nail tip design, even in the hands of the experienced surgeon? And do you feel that it has something to do with the hockey stick design of the nail round, and does the design have to do something with that?
Yeah, that's a very important question, I guess. Very, very important question. We have seen this also in our hand, as you mentioned, and we try to analyze what are the factors, why perhaps the nail can penetrate the bone or easily penetrate the bone, or we cannot manipulate it very easily, or it's not stable enough. So first of all, we have checked the entry point. We made investigations about entry point in different angulations. Normally we say 45 degrees, but you can go also in 50 or 60 degrees, but not below of 45 degrees, because the nail tip in our nail is exactly designed to the shape of the bone on the other side. That means if you are even too perpendicular, you stick in the bone. Of course, this is the problem. But this can happen also during insertion, and this has something to do with the bending. Once you pre-bend the nail too much and you do not realize it, then the nail comes in and sticks on the other side in this way, and is bended very well, and then you do not realize it, and you start to hammer, and then you break it, of course, or you stick, or then you start to twist the nail, So therefore, you know, I remember 30 years ago when we made workshops, we were always using the hammer. In the meantime, in the workshop, we say use even in the femur, only by hand, rotation by hand, feeling, the hand feels the bone, and only slight hammer blows, not more. So it has changed. So it has to do, but for me, the main factor is the indication. Not to realize that the medullary canal has not the correct size, or the fracture is more problematic. So for me, even in my hand, if I get in troubles, I guess I'm considered was the indication correct or not.
Right. So there is one more question here. There is somebody who is asking, what should be the size of the nail in the forearm bone? Do you recommend 80% of the canal diameter?
Exactly, it's good. I did not mention this in my talk because I did not speak about forearm fracture. It's special, but that's correct. As we are using only one nail per bone, it's 60%. It's 60% of the medullary canal. That means in the majority you are using 2.5, sometimes 3 millimeter bone. In refractures, I can tell you only in refractures, you will see in India, I guess you see a lot of refracture coming to your clinic after 3-4 weeks. Conservative treatment of a forearm and then plaster away and then refracture. This is a good indication for nailing. And then we are using a 3 millimeter, which is a little bit stronger. I cut a little bit the tip, and then I can really go to the callus and then through the callus hammering and go through. This is a fantastic method. Then 3 millimeter, but 60% normally.
60%. Yeah, there's one more question here. Any tips to get a perfect spindle at distal fourth tibial fibular fractures with TENS? In distal fourth fractures, any tips in tibial fractures? Distal fourth tibial fractures.
Yeah.
Somebody is asking you to give the tips to get the perfect spindle at the fracture site.
You know, I have to answer in other way. You know, for radial neck fracture, it's like a metaphyseal fracture. For proximal humerus, as well distal humerus fracture, even for proximal femur fracture and distal femur fracture, we can use in this distal fourth or third the nail. But on the tibia, as I showed in my graphic, it's very, very problematic. You know, because of the shape of the bone. I would say if you fix a distal tibial fracture with elastic nail, you must be a so-called advanced nailer. It's not a beginner. You should have some experience and skills and to play with all the nails. It's really, you can do this, but I guess I would not recommend this for a beginner. The trick is the first third of the nail must be prevented much more so that at the end, when the nail comes down, it goes medial and lateral, you know. This is a trick, but again, I would say it's not the beginner's fracture.
That's very
Other
important.
Questions?
Right.
Yeah,
there is one more question.
Yeah, Sheetal.
No, but what is the downside of retaining the nails, not removing them?
Can we continue on questions, Dr. Prema?
I did not understand the question because I had 2 voices or 3 voices together.
Dr. Ramani, go ahead.
Yeah, sorry, you carry on.
Sheetal, okay. What is your question, Sheetal?
What is the downside of retaining the nail, not taking them out?
Yeah. This is more and more of importance nowadays. Okay, first of all, it's not a question, can we leave the nails in or take it out? It's always possible because we have, before we had the talk about spine fractures and the scoliosis. You know, when you make a scoliosis, you are happy that the implants remains always inside. And I say to the parents, if you have a total hip, you are happy and the total hip never comes out. That is not the question, can we leave it in? The question is, makes it sense? And in US, more and more it's popular, but this is the money, only because of the money. And if you plan to leave the nail in, then you have to cut it very close to the bone so that does not disturb the skin. But if you will remove then later on after 3-4 years, you know, the nail in a young child migrates up, and then it's very difficult to remove it. I remember a case. It was a pathological fracture in a bone cyst in a 14-year-old boy in a proximal femur. I did it in elastic nails, 3 and it was fantastic. And then the patient was 21 and made a new fracture. And then he came to Professor Gunn's clinic, and Professor Gunn was operating in the night, and the nails were still inside. And he said, "Oh, call Dr. Slongo. He had to remove these stupid nails for me in the night, you know." So this is a question, makes it sense or not? More and more, it's popular to leave it in. More and more. No second operation and no lower price. What is the practice in your clinic?
We tend to remove them, you know, between 6 months and a year. Most of it, especially the younger patients. I mean, those who are very close to adolescence, like 12, 13 years of age. Some of our physicians are leaving it in, but younger patients, we tend to remove them. Those less than 10.
In our clinic, in principle, exactly the same. Up to 14, routinely we remove it.
And my next question is that, what do you think? There is a new design. I think it was Matteso's son who came out and published.
Matteso's son.
Yeah, it's a D-shaped nail instead of the round nail, and you know the advantages are that you get a better grip. You get, you know, the biomechanical studies showed that it was pretty equivalent, but it's less radiation because you know which side the nail is going. And so there were some advantages of using a D-shaped nail instead of the round nail, and some companies are promoting that new shaped nails. What are your thoughts on it?
I got these nails from the company, and I tested it as well. You know, that's correct. And it's the same idea we had in the Depisynthesis with this line on the end of the nail, that you have always the orientation, where is the tip, that you can reduce irradiation. But you know, also in your experience, once you have rotated a little bit, that means the nail tip and the rest of the nail is not in the same alignment. So it does not help that the nail twists a little bit. So this is not correct. It's much better what I say with this T-handle, with the asymmetrical bars, that you remember on the short part, you have the tip, on this side is the other side. So the disadvantage I have seen, the question before, you know, in the Metazoid Junior nail, the nail tip is very sharp. It's very sharp. And if you do not glide very tightly, it sticks immediately fast in the elasticity is the same. But you know, what you have to know, you can play with elasticity. You know, what the people do not know is that all these titanium nails, especially titanium nails, are not a poor titanium. This is always 95% of titanium, and some are vanadium, and other have niobium. Niobium makes the titanium weak, and then you have to make a trick by heat treating to make it stronger and more elastic. And with this trick, you can bring the elasticity much higher, much higher. With vanadium, what is the original nail, and in Japan perhaps they are always with these are more stronger. So this is a little bit the problem of the alloy you have. But the Metazo nail is okay. Yeah, Taral.
Taral, unmute
Taral, you are muted.
So always we are looking at an AP X-ray, say of femur, and we look at the 3-point in only AP X-ray, mediolateral. What happens to anteroposterior? Because there are forces and muscles in front and back also, and there are, how do you sort of neutralize these forces? Flexion extension.
Yeah, it's good. Yeah, because of varus and valgus, you mean, huh? In the AP view, that we have an equilibrium of the forces. The ideal situation is that in the lateral view, you have two parallel nails, two parallel nails. And because, you know, in the lateral view, this is the view where the joint is working. This is in the plane of movement. So therefore, this stability is not so important because it's in the rotation, in the axial of the joint as varus valgus. So therefore, we are more focused on varus valgus than of perhaps in the femur, the anticurvation. This is the reason, varus valgus.
So how do you maintain the natural bow of the femur?
The lateral bow. Yeah, this is a little bit the trick. I try to do this if it's not comes automatically by a symmetrical bracing. Then this is also advanced nailing. Then I pre-bend one nail a little bit more than the other one. I do not use different thick, but pre-bend a little bit more. So well, once you do this in a model, you can see very nicely, as you have seen before in my video. I hope you could see this, how you can play with this. I have some cases with really refractures. The tendency to varus was so strong that really I was using two different nails diameters to compensate this force.
Yeah, I had one question for the radius and ulnar nailing. Are there any tricks of which bone to nail first? Because if you nail the radius, sometimes it's difficult to get the ulna in the position. And I've heard about distal ulnar entry points just to make it easy for insertion, like come distal entry with the ulna. What are your thoughts about which bone to nail first and how to make it easy? Any tricks?
Yeah, okay. First normally we say this is a recommendation. We say we start with the more difficult, that mostly is the radius, because you cannot palpate the radius as well as the ulna, but it's not always correct. But normally we say with the ulna or with the radius, we say mostly with the more complex or difficult. But now with the distal entry points, radius and ulna, this makes your reduction much easier, because now, first of all, from your thinking, you have to not come in this way. You know, this is very difficult to work. You have to rotate always. No, you are coming from this way. That means you're thinking in the same way. Then you can, alternatively, you can go forward with this or this or this or this. And then you have the joystick, you know, and then you can advance the radius more or the ulna more, so you can play with both together, what is not possible in the old technique. So then I have the joystick, both goes together. Then I see, okay, now with this, I do reduce this, and then I go forward with this or with this. This is the advantage of this distal entry point for both. And we do 100% in this way nowadays.
Is there, I mean, there is a risk of the branch of the ulnar nerve on the distal ulna? Do you just less like you have it with the radius? Less than
here. The only point is now with this new technique, with the different entry points, we can play a little bit according to the morphology of the fracture. You know, if the ulnar fracture is really in the distal third here, then I come from here. But for all ulnar fracture from the middle part to here, I go from this way. And especially for Montecchio lesion, Bardo 3, with only bowing here, very proximal, you should not come from here, then it's a floating fragment. No, then you come from here, and then you can manipulate the fragment very easily. This is fantastic for Bardo 3.
Good point.
Okay.
There was one question. Can you bend a nail in more than one plane to counter forces depending on planes of fracture?
Oh, in principle, I guess you can do this, but it would be technical, very demanding to do this in both ways. And I guess as soon as you insert the nail, the pre-bending in one of the plane will disappear. You remember when you insert a straight nail in the bone, and you remove it, it has a pre-bending, you know, and why not? I never did it. I never did it. Why not?
Dr.
New
Slongo,
idea. New idea. It's good.
Yeah, Dr. Slongo, I have a question. Do you routinely recommend bending of the nails after insertion at the end? I mean, especially after the retrograde nailing of the femoral fractures, do you routinely recommend bending? Are you recommending it only when you are putting the end caps, or otherwise, if you don't put the end caps, do you still recommend bending of the nails?
No, as you have seen in some of my examples, when I was not using the end caps, the end of the nail is only bent a little bit. That means if it is inserted in this way, so initially we made this, you know, we made this. Now we pre-bend it, no, we bend it only a little bit away so that it is not pressing, but not really round. And we say, but I check always that the end of the nail is under the fascia, So why I lift it up, I will not say bend, I lift it up a little bit. This makes removal much easier. Otherwise, the nail sticks in the bone. But it's not a real bend. It's only a little bit lift up. And with this beveled impactor, you know, when the beveled impactor goes over this to the bone, then you can make a little bit like this only, and then it's a little bit like this, and not bended like this.
And another question is that in forearm bones, when we are talking about putting a nail 60% of the medullary diameter, then we are really not focusing on putting the same size nails. There could be 2.5 millimeters of nail in the ulna and 3.5 millimeter nail in the radius. You are not bothered about that.
That I would not recommend. That I would not like this. Again, if you are an advanced nailer and you have experience and you exactly knows what you are doing, then why not? But the problem is, I play also with the nail, you know, sometimes my construct looks very crazy, but I know why I do this. But the most failure we see, the people do not recognize what they are doing. And this is the problem, you know, when you exactly know, so say, I'm using different diameters because of this, and this, and or different bending because 1, 2, 3, it's okay. Then it's okay, because then you have a reason. But the problem is that most of the surgeons do not recognize this.
But then, you know, you always have a difference in diameters of radius and ulna. So are you still focusing on putting the same size nails in both the bones?
Yeah. I can tell you, I guess I never did different, inserted different nail diameters. I can't remember me. I guess never. No.
So the point of putting in a 60% of the diameter nail in a forearm bone, then in the fracture of both radius and ulna, probably doesn't hold true, isn't it?
Yeah, yeah. When you are very, very, very critical, you are right. You're right. But then it depends on which level you measure the diameter of the medullary canal. So we said, okay, normally when you look at the midshaft here, the midshaft, analyze a little bit a normal X-rays. I guess at this level in the middle third, both bones are nearly in the same diameter. Mostly.
I had one question. You know, after we cut the nail and we give our last few like impact, blows to insert the nail further in, sometimes you have seen the tip of the nail changes, you know, like during the last impaction. Is there any way to prevent that, or any tricks of how you can prevent, because the nail is already cut, so it's very difficult to then rotate the nail. Is there any way for you to any tricks?
Yeah, I guess that the nail goes in the canceller bone in a special direction, and it goes always in the same direction because of the canceller bone. And I have seen this. Then I pull it back. I take a vice grip or the removal clamp, the removal forceps or clamp, and hold the nail and tuck it in that he remains in the correct position. You know, then I, with the forceps, I hold the nail that he cannot rotate. This is the trick.
Yeah, so I think it's better
First,
to
I
put
pull
the
it a
nail.
little bit back.
Yeah, I think it's
Yeah.
a better way of, you know, putting the nail in the final position, then backing it out a little bit, then cutting and impacting it, then it will go in the same
Exactly.
position. Otherwise, in the
Exactly.
last few blows, it can change the tip.
Yeah,
And
because of the cancellar bone, it goes in this way, especially in the femur medial side. This is correct.
Yeah.
Correct. So therefore, I go in the position. This was the original OP technique. I recommended it. Go in, push it back, pull it back, cut it, go in the same direction. Okay, good.
Perfect. Very nice.
That's it.
I think the last question that we'll take is, what is your preferred entry point for the for the radial nail? Is it Lister's tubercle or styloid?
In the meantime, in our hand, even some ruptures of the tendon are reported, is the Lister tubercle. Depends a little bit in the meantime also from the fracture. This is now the advantage we have. The advantage we have with the different techniques, that depending on the fracture, I'm using the different entry points. That means, you remember my square for the metaphyseal fracture, the square of the medial fracture. When you go in the traditional entry point for a very distal fracture, then you have the floating fragment. When you go through the Lister tubercle, then you can fix this fragment, even in this square, on the border of the square. That means if a very distal fragment, I go by Lister. If it's a midshaft, I go more by the traditional.
Radial. Okay. Thank you.
Just for those who don't know what the square is, the side of the square is the distance or the width of the physis. Physis of the radius is the physis of the ulna.
Yeah, the basic of the square is the line over radius and ulna physis.
So that's the width, and that is how you, decide.
Yeah.
Yes.
Both
yes.
bones. This is the sort of trick.
Thank you.
Okay.
Thank you.
This was a pleasure. Thank you very much.
Thank you
And
very much,
again,
Dr. Slongo.
I can congratulate to your great 4 weekends. That's unbelievable. Thank you.
Professor Slongo, thank you very much for this wonderful lecture. You know, one of the best lectures I've ever heard on pediatric trauma in my life. A lot of clarity, a lot of new points. And I would request Sandeep, actually, though we are not able to give him an actual oration plaque, you know, do it in a virtual manner. This whole conference has been virtual. So why not the plaque be a virtual plaque? So Sandeep, you start talking and I would release the plaque.
So Dr. Slongo, it's been a pleasure and an absolute honor that you accepted our invitation for the IFICS Oration, and we were fortunate that you have been part of this journey over the last 1 month, and IFICS Foundation is honored to have you to deliver the IFICS Oration 2020 on the topic 37 years of experience with SN. Where do we make mistakes and why? Thank you very much. We are indeed honored and privileged to be part of this lecture. And let me inform you that more than 1,600 people have watched your lecture on various forums, Facebook and OrthoTV. And we had about 150 people on the Zoom platform. So I think you deserve a standing ovation. Thank you very much.
Thank you.
Thank you very much, Dr. Slongo. Good night.
Good night.
I would also like to thank Dhiren Bhai and Ramani for gracing this occasion, and Viral and I think Patrick is gone, and Dr. Rajshekharan, Arjun and the spine team for that wonderful 1.5 hours of spinal trauma and interactive cases. So I guess with that we will sign off, and looking forward to physical IFICS next year, Sheetal. Hopefully there will be no virus then. So we hope to see you back in India soon.
Thank you very much.
Okay, you have to work on a vacation.
Good night.
Vaccination.
Pleasure,
On a
pleasure to be
vaccination,
Yes.
you
here.
have to
Thank you very
work.
much. Good night.
Okay.
Thank you. Thank you.
Okay, so that was good. I think we are 1 hour late, I think, but it was, I think,
Yeah.
worth it.
Absolutely.
That's fine.
People are.
It was our last.
It was
so last
fantastic.
session.